If you're talking about the syndromes, again, the ones which are more importantly asked from the exams perspective, Dubin-Johnson syndrome is one example of a syndrome that we need to keep in mind, which is having a defect in the MRP protein. And these are the patients who are having two important findings. One, they have a jaundice, which is because of a direct bilirubin. And the second thing is, if you're going to be looking at these liver patients, these patients are going to be having a pigmented liver. So Dubin-Johnson syndrome, patients have a dark appearing liver because of the presence of epinephrine metabolites, and they do have the presence of a jaundice as well. If you are talking about a condition which is given the name of Rotor syndrome, Rotor syndrome would be an example of a condition in which the patients are going to be having the conjugated hyperbilirubinemia. But how do you distinguish it from a patient suffering from Dubin-Johnson syndrome is that there is going to be no pigmentation of the liver. So those four syndromes, Gilbert syndrome, Crigler-Najjar syndrome, Dubin-Johnson syndrome and Rotor syndrome are what are more frequently asked as MCQs, even though clinically the common causes would be hemolytic anemia for unconjugated hyperbilirubinemia and stones obstruction because of a malignancy or a fluke infection because of responsible for causing conjugated hyperbilirubinemia. Have an example of a discussion on disorders which can also cause development of conjugated hyperbilirubinemia, that is going to be biliary tract disorders. First disorder can be a condition which is given the name of primary biliary cirrhosis or primary biliary cholangitis. This condition is characterized by the presence of a autoantibody that is given the name of anti-mitochondrial antibody. The condition is typically going to be associated with the damage or destruction of the intrahepatic ducts because of a granulomatous inflammation. This condition affects females who are going to be having an age of 50 years. And it has been shown to have a definitive association with patients who are going to be also having the development of Sjogren's syndrome. Microscopically, you are going to be having the presence of a granulomatous lesion over here. So that's going to be associated with the term florid duct lesion. In contrast, if I'm talking about a patient who is going to be having primary sclerosing cholangitis, the antibody that is seen in these individuals is going to be P-ANCA. There is a destruction or involvement of both intrahepatic as well as extrahepatic ducts. This condition surprisingly affects younger males. So males are more commonly affected, and that in the younger age group. And this has got a definitive association with ulcerative colitis. Both these conditions clinically have a relevance. Apart from causing jaundice, both these conditions increase the risk for development of liver cirrhosis in the patients. And they also are associated with high risk for development of liver cancer in the patients. Microscopic finding for primary sclerosing cholangitis would be the patients are going to be having the presence of an onion scaling of the bile duct. So bile duct is going to be having an onion scaling. That is what is going to be because of the deposition of the fibrous tissue in this peculiar fashion. This is what we need to remember so far as primary sclerosing cholangitis is concerned. Having said that, let's have a word or two about cirrhosis. Even though it's an example of a condition which is likely to be discussed with you in medicine, the mechanism or the important feature of cirrhosis that we need to remember over here is there is going to be a destruction of the liver architecture. And because of the destruction, there is going to be a deposition of the fibrous tissue. And to compensate for it, you would be having the presence of regenerative nodules. The commonest reason for development of cirrhosis happens to be usually alcohol intake. And if you exclude alcohol, one of the important reasons nowadays happens to be a condition that is given the name of non-alcoholic steatohepatitis. Patients are going to be having cirrhosis because of secondary to some kind of inflammatory condition like hepatitis, or because of the different types of metal overload conditions. Say, for example, Wilson's, copper overload condition, or iron overload condition like hemochromatosis. Patients would be having the clinical findings that are going to be including portal hypertension. They may be having splenomegaly, the esophageal varices, or caput medusae. They can be having the presence of a very important finding ascites. Because the liver is not functioning properly, so clotting factor synthesis is affected. Therefore, the patients are going to be having an increase in the PT and the APDT. Improper metabolism of estrogen is going to be responsible for causing development of findings like spider angiomas, as you can appreciate it over here. So this was the example of the presence of caput medusae that can be seen in the ascitic abdomen of an individual. This is the presence of the caput. This is going to be the presence of the spider angioma. You're going to be having the presence of palmar erythema, and the patients are going to be having a flapping tremor. That's what you need to remember, primarily because of the presence of increased ammonia. Liver problem is also going to complicate the functioning of the other tissues in the body, for example, the lungs as well as the kidneys. So that's what is being termed as a hepatorenal or the hepatopulmonary syndrome. When we are talking about the alcoholic liver disease, it can have three important subsets. One can be the first condition in which there is a fatty deposition, which is given the name of fatty liver or alcoholic steatosis. This is an example of a condition in which the patients are going to be having fatty droplet deposition. The second condition can be in which the patients are going to be having deposition of fat as well as inflammation. That's called as steatohepatitis. And one of the findings that we have over here is the presence of Mallory-Denk body. Mallory-Denk body is an example of an eosinophilic structure that is present inside the hepatocytes, but it can be seen in a lot of other conditions as well. When we are talking about the Third and the last stage, which is going to be seen with alcoholic liver disease, that is called as alcoholic cirrhosis, also called as line cirrhosis. The patients are going to be having replacement of the hepatic tissue by the fibrous tissue and collagen deposition. Therefore, this is something that can be picked up with the help of Masson's trichrome stain. Clinically, a patient who is going to be having alcoholic liver disease would classically be having the presence of the AST-ALT ratio, which is going to be more than 2:1. These patients are also going to be at times having a condition, without alcohol, as you made a mention, what condition that is given the name of non-alcoholic fatty liver disease. It's usually a diagnosis of exclusion, and the way to distinguish that would be: one, the patient is not having a history of alcohol intake. Second, in case of non-alcoholic fatty liver disease, if you look at the ratio, it is the AST-ALT ratio, which is going to be less than 2. This condition, we do not know the cause exactly, but may be associated with the conditions like metabolic syndrome, obesity can be there, dyslipidemia can be there, insulin resistance is going to be there. So it is going to be associated with the term cryptogenic cirrhosis. Why that's important is it is increasing in prevalence these days on a very rapid scale, and it is going to be causing mortality of the patients because of a cardiovascular cause. Having a quick recap of the table with regards to the infectious cause of the hepatic tissue inflammation, that's hepatitis. So we have got the different types of viruses from A to E, in which the hepatitis viruses A and E are responsible for causing acute hepatitis. We remember acute hepatitis, the cells are going to swell up, so they are going to be having the presence of a ballooning degeneration. You could be having the presence of patchy or spotty necrosis over here, and you could be having the presence of even the apoptosis taking place over there, which is going to be associated with the term Councilman body. If you look at viruses B, C, and D, they are the ones which can cause acute hepatitis, but they can also be responsible for causing chronic hepatitis. And chronic hepatitis is going to be characterized by ground glass hepatocytes, so big size hepatocytes in which you're going to be having the presence of a ground glass appearance. You could be having the presence of piecemeal necrosis, and along with the necrosis can extend, so that's going to be associated with the term the bridging necrosis, and there can be fibrosis. Just quick recap about the important features of individual viruses. Hepatitis A is going to be having a fecal route of transmission, and this is going to be seen very commonly in case of children. Carrier stage is usually absent. Hepatitis B, big time trouble that we need to remember over here. It is going to be a very common reason for development of hepatitis after blood transfusion, and of course it increases the risk of development of the carrier state in the patient. It is going to be responsible for causing high risk of development of liver cancer as well. Certain antigens of hepatitis B are commonly asked in the exam. Surface antigen, which is the first antigen to appear. The E antigen, which is a marker of infectivity. The core antigen, against which you have the trouble which is going to be not appearing in the blood. When we are going to be talking about the hepatitis C virus, it is responsible for high risk of development of chronicity as well as cirrhosis. And a characteristic feature of hepatitis A is presence of a fatty change. Big time important thing that is asked in the exam. Hepatitis D, the Delta virus, is not going to be causing the infection on its own because it is defective, and therefore it requires the help of hepatitis B for causing infection. So it can be a co-infection or it can be an example of a super infection. Hepatitis E is what is going to be causing the trouble in case of expectant ladies, expecting weight mothers, and therefore it can result in a very fulminant or very aggressive kind of hepatitis, especially at the time of pregnancy, which can contribute to the development of mortality. Once we are clear with this, we just need to be aware about certain types of metabolic disorders in which we need to be having an idea about alpha-1 antitrypsin deficiency. This is going to be an example of an autosomal recessive condition caused because of a trouble at the level of chromosome number 14. Patients not only have cirrhosis, they also have high risk of development of a pan-acinar emphysema. How would you confirm the presence of alpha-1 antitrypsin deficiency? These patients are having the presence of PAS-positive diastase resistant granules, right? So we have talked about this time and again. PAS-positive and diastase-sensitive granules are a feature of glycogen. PAS-positive diastase-resistant granules are a feature of alpha-1 antitrypsin deficiency. If we talk about an iron overload condition, that is hemochromatosis, that's seen because of HFE gene mutation on chromosome number 6p. Patients are going to be having not only the problem with the liver, they also have a damage of the pancreatic beta cells. They also have hyperpigmentation of the skin, because of which the name given to this condition is bronze diabetes. So there is hepatic problem, there is a pancreatic problem, and there is a skin pigmentation as well. Bronze diabetes is the term that is being used. A lot of these patients are going to be having the involvement of the hypothalamo-pituitary adrenal axis, because of which the patients are going to be having a testicular atrophy. So it is a condition seen more commonly in case of males, and the males can have a complication that is going to be testicular atrophy. The detection of iron in high amounts in these patients can be done with the help of Prussian blue stain. And Prussian blue stain, as you can understand, is going to be giving the iron, the hemosiderin, a bluish color, and that reaction is given the name of Pearl's reaction. Diagnosis, of course, would be requiring the presence of extra amount of iron being deposited or hemosiderin being shown in the liver biopsy. Any patient who is going to be suffering from a copper overload condition, that's what is going to be given the name of Wilson's disease because of ATP7B problem. ATP7A problem was seen in case of Menkes. ATP7B is Wilson's. This condition is going to be having an involvement of Chromosome 13 as an autosomal recessive condition. Again, apart from liver, you can get involvement of the CNS in the form of involvement of basal ganglia. So patients can have a development of Parkinsonism. These patients can also have ocular involvement in the form of Kayser-Fleischer ring, as well as the presence of finding which is going to be given the name of sunflower cataract. A lot of patients who are going to be having Kayser-Fleischer ring are going to be having an important finding. There is going to be neurological involvement in such patients. So sometimes patient may not be having a neurological dysfunction initially, but if you on eye examination find that there is a KF ring, then the patients are likely to have a development of neurological manifestation subsequently. Patients can also have a development of hemolytic anemia in this condition. Please remember the fact, even though it is an iron overload condition, but serum copper is not. I repeat that serum copper is not useful for making a confirmatory diagnosis for this condition. So how will you confirm your diagnosis? Your diagnosis will be confirmed on the basis of liver biopsy, which can show you the presence of high levels of copper. How would you identify copper? Copper is going to be stained with the help of stain, which is given the name of rhodanine. Microbiology link, do not confuse it with oramine, rhodamine, which you use for mycobacterium. So oramine is going to be used for staining copper, and this is going to be giving a reddish color to copper. That's what we need to remember so far as the different examples of metabolic disorders are concerned. Final thing for discussion with regards to the hepatobiliary system happens to be the tumors. Important example of the tumors are going to be liver is an important site for the spread of the tumors because of its dual blood supply. So that's going to be metastasis. If you talk about a special tumor, that's given the name of a cavernous hemangioma. It's a benign tumor. Cavernous hemangioma is a benign tumor. This tumor being very vascular has a problem that it may bleed if you biopsy it. So biopsy is to be avoided, or it has to be done cautiously. This cavernous hemangioma can be associated with the big caverns or big areas which are going to be filled with blood. So this is going to be associated with a syndrome as well. That's the name of Kasabach-Merritt syndrome. Kasabach-Merritt syndrome. We do have another important condition asked in the exam. That is going to be focal nodular hyperplasia, and the keyword over here is it is having the presence of a central stellate scar. When we're talking about the tumor that is going to be given the name of hepatic adenoma is going to be classically having an association with oral contraceptive pill intake. So young female having a history of OCP intake is going to be having hepatic adenoma. That's what we need to remember. Of course, microscopically or at a genetic level, we have a subtype of hepatic adenoma which can be having the presence of a beta-catenin mutation, and that is the one which is having a risk of progression into a cancer in the future. Patients having hepatic adenoma can present with acute abdomen because of the tumor increasing in size and can be having a subcapsular rupture. When we are talking about a tumor that is going to be given the name of hepatoblastoma, hepatoblastoma is going to be an example of a tumor. Blastoma word would give you a hint. It's an example of a tumor that is seen in a child, and this tumor is going to be a malignant tumor having high AFP levels. Next one that we need to have an idea is going to be angiosarcoma that we have talked about in neoplasia as well. It's an endothelial cell tumor, and this tumor is going to be remembered with the risk factors that we are aware. That is going to be tap your brain. So thorotrast, arsenic, polyvinyl chloride. Thorotrast, arsenic, polyvinyl chloride. That's what we just need to recall over here. Very quickly, we can talk about hepatocellular carcinoma, which is a very, very common tumor, primary malignant tumor that you have in case of adults. This can be seen in case of individuals because of presence of an infection caused by hepatitis B. This is also having an association with something like alcohol intake. This is also going to be associated with exposure to a toxin like aflatoxin. We do have novel markers nowadays apart from alpha-fetoprotein for detection of hepatocellular carcinoma like arginase 3, and the other novel marker which has been asked in one of the INI-CT exams earlier happens to be HepPAR1. If a patient is going to be having the presence of hepatocellular carcinoma, one of the important sites where the metastasis is going to take place is going to be lungs. One of the important features that you need to remember is hepatocellular carcinoma is a cancer that is seen in case of elderly individuals. However, there is one variant of hepatocellular carcinoma which is seen in case of young people, and that is given the name of the fibrolamellar variant. The fibrolamellar variant is important because it is going to be affecting people of the younger age. It is not related with the classical risk factors that you have for hepatocellular carcinoma. So no association with hepatitis B and C, no association with alcohol intake, no association with aflatoxin. Then of course what you would ask is, how is it going to be caused? It's caused because that we know it is having a definitive association of a particular marker which is going to be associated in its pathogenesis, that is the PRKACA DNA JB1. So एक प्रकार का अलग टाइप का DNA जब ये प्रेजेंट होगा, पेशेंट इज गोइंग टू बी हैविंग अ कैंसर. एक प्रकार का कैंसर जो DNA के ऐसा होने पे present होता है. The marker that we are having is not alpha fetoprotein over here. The marker that we have over here is a special marker that's given the name of neurotensin. Why should we be familiar with this? 4 differences: younger patient, classical risk factor is not there, the oncogen is going to be different, and the marker is different. And the practical relevance is this is an example of a cancer which is slow growing. So it is an example of a marker, or it's a type of a hepatocellular carcinoma which is going to be associated with a good prognosis. better prognosis. So that's a quick recap that we need to have over here. And this is going to be an example of a fibrolamellar variant of the hepatocellular carcinoma, the one which is going to be having a good prognosis, right? So that is what we need to just have an idea so far as the discussion of the hepatic tumors is concerned. In fact, that takes care of a discussion of the disorders of the hepatobiliary system. Let's start with the next important topic and let's have a heart-to-heart chat. That means we're going to be having a discussion about the cardiovascular system. Now, when we talk about the cardiovascular system, let us first have an initial discussion about the vascular pathologies. Then we are going to be having a discussion about the cardiac disorders. Now, having a discussion about the vascular disorders, starting off with the most important topic, which is going to be vascularity disorders. The first example of vascularity disorder that we need to talk about over here is a large vessel vascularity disorder, which is given the name of temporal arteritis. Of course, it's an example of the commonest vascularity disorder that we have in the patients having an age more than 50 years. Patients are going to be having the presence of manifestations, which include the presence of the commonest manifestation being headache, the specific manifestation being jaw claudication, and the patients are going to be having complaint of polymyalgia rheumatica. Why we need to talk about this condition is because it can have a sudden onset of blindness as a complication in the patients, and a very important example of a vascularity disorder in which you have high value of ESR. Ideal investigation to be carried out in these patients is a temporal artery biopsy, which can show you the presence of a granulomatous inflammation and having therefore the presence of giant cells and the fragmentation of the internal elastic lamina. To see for the fragmentation of the internal elastic lamina, you are going to be using a special stain which can be useful for picking up the elastin fibers, and that special stain is what is going to be given the name of the Van Giesen stain. So Van Giesen stain is useful for picking up the elastin fibers. So this fragmentation of the internal elastic lamina is something which is going to be a characteristic feature. Because you do not want your patient to have a vision loss, so you have to give your patients IV steroids at the earliest so as to reduce the chances of having a vision loss. A second example of a large vessel vascularity disorder, also an example of a granulomatous vascularity disorder, is Takayasu arteritis. Takayasu arteritis is going to be associated with other names like aortic arch syndrome, and this is also going to be associated with the name pulseless disease. It's a condition which is going to be seen in point number 1, people having an age less than 50 years. Patients can have weak pulses. They can be having the presence of neurological manifestations as well, and patients have renal vessel involvement. Let us not forget that these patients can also have the same complication just like the temporal arteritis, which is sudden onset of blindness. Now, what is the significance knowing about the renal vessel involvement? It can precipitate in this patient hypertension. Therefore, the patients can be having a development of renovascular hypertension. Radiologically, you could be having the presence of a situation where the patients are going to be having the involvement of the big vessels, and there is going to be a tremendous narrowing that can be observed in the angiograms. So that is what is going to be responsible for the clinical finding as well, which was in the form of the pulseless disease. How do you treat this condition? The treatment of this condition happens to be again done with the help of steroids. When you are talking about medium-sized vessel vasculitis, multiple conditions about which we need to have an idea. First, talking about polyarteritis nodosa. Polyarteritis nodosa is an example of a condition affecting young adults. There is an association of hepatitis B with this condition. So, hepatitis B antigen and antibody formation results in the formation of immune complex. Therefore, it's an example of an immune complex disease. I can say it's an example of a type 3 hypersensitivity reaction. Even though multiple vessels can be affected in the body, but what we need to remember is the pulmonary vessels are going to be spared. Another characteristic finding, patients can have kidney involvement, they can have renal involvement, but we do not find any glomerulonephritis in such patients. Because of the presence of inflammation at multiple areas in the vessel, the patients can be having development of a patchy fibrosis, which is going to be associated with the name string of pearl appearance. String of pearl appearance. Another important example of a vascularity disorder, which was asked in the 2024 exam as well, was Kawasaki's disease. It's an example of a pediatric vascularity disorder. Patients are diagnosed with the help of the fever plus screen criteria. So fever is sine qua non. It's present in 100% of the patients. Patients are going to be having conjunctivitis. This is what they'll have to ask you, and this is what they ask you in the UPSC exam as well. This is classically non-purulent or non-exudative conjunctivitis. Patients are going to be having the presence of a skin rash as well. They would be having the presence of edema of the hands and feet. There is a presence of a unilateral cervical lymphadenopathy as well, and patients are going to be having the presence of mucosal involvement as well, which is going to be seen in the form of a strawberry tongue. Whenever we are talking about Kawasaki's, we study it because it is one of the important reasons for development of myocardial infarction in case of children. The moment we are talking about a condition which is given the name of Berger's disease, it's a condition of young male and especially having a history of smoking. Patients classically are going to be having the complaint of intermittent claudication. So there is a pain on walking and there is going to be an improvement on taking rest. One of the characteristic vessels involved over here is the tibial vessel. Apart from that, we can have involvement of the popliteal artery or the radial artery as well. So this is a condition in which there is a hypersensitivity reaction to nicotine, and therefore patients are advised to quit smoking. They are given vasodilator drugs for symptomatic improvement, and they are going to be at times requiring omentopexy, or they may require even limb amputation in the extreme cases. Whenever we are talking about the important features, this is what we need to remember over here. So polyarteritis nodosa is going to be characterized by the presence of fibrinoid necrosis. That is what we find. There is going to be an issue with respect to Kawasaki's narrowing of the vessels, that is going to result in precipitation of a heart attack. And when we are talking about the patients having young male smokers having the presence of peripheral decrease in the blood supply, that can be responsible for causing, high risk for development of ischemic gangrene. And you are going to be having the presence of an occlusion of the vessel in this kind of a fashion. We then are having certain vascular disorders which are associated with presence of an antibody which is given the name of ANCA. ANCA which is going to be given the name of P-ANCA, which is now called as MPO ANCA. And we were having an ANCA which is called as cytoplasmic ANCA, which is now called as PR3 ANCA. They are seen in different conditions about which we need to have an idea. So PR3 ANCA is what you are going to be associating in a condition which is granulomatosis with polyangiitis. Whereas other types of vascular disorders, whether it is microscopic polyangiitis, whether it is Goodpasture syndrome, whether it is ulcerative colitis, or whether it is the EGPA, they are the ones which are going to be associated with MPO ANCA. So easier for you to remember, PR3 ANCA, just one condition, granulomatosis with polyangiitis. Having now a discussion about the small vessel vascularity disorders, we need to be familiar with the condition that is given the name of GPA. GPA, which was earlier called as Wegener's disease. It was having the presence of three important organs: kidney, upper respiratory tract, and lungs. Because of which patients are having presence of cavitary lesion in their lungs. They are having the presence of a high risk of development of glomerular inflammation, which can even progress to crescentic glomerulonephritis. ENT involvement can be seen in the patients in the form of otitis media, in the form of the development of strawberry gums, in the form of development of subglottic stenosis. Whenever we are talking about granulomatosis with polyangiitis, diagnosis is done with the help of PR3 ANCA, and these patients have an excellent response to cyclophosphamide administration. A second one which has been asked in the exam happens to be IgA vasculitis disorder. This is also seen in case of children, just like Kawasaki's, and this condition was earlier called as Hinox-Schönlein purpura. So 4 organs were affected. First was kidneys in the form of glomerulonephritis. Second is skin in the form of a palpable purpura or non-thrombocytopenic purpura. Patients were having a rash as well as an extensor surface rash on their back and their buttocks. And the patients were having the presence of GI tract involvement and joint involvement. GI tract involvement can result in development of bleeding. So that is one of the reasons why the patients may be started on something like steroids, or the patients could be having a joint pain as well. If a patient is going to be having IgA vasculitis, the name gives you a hint, there is increase in the pathogenic Ig in these patients, and that's an example of a type 3 hypersensitivity reaction. Please remember the fact, presence of GI bleed, presence of RPGN are indications for starting steroid therapy in these babies. We have a condition that is going to be given the name of Behçet's disease. Behçet's disease is also given the name of oculo-orogenital syndrome. That's why you associate it with the triad, and the triad is oral ulcer, genital ulcer, and uveitis. Oral ulcer, genital ulcer, and uveitis. This condition is going to be having an association that there is going to be neutrophilic infiltration, and it is going to be diagnosed with the help of a test that is given the name of Patho4's test. Patho4's test is a term that you associate with a patient having oculo-orogenital syndrome or Behçet's disease. Having a word about example of conditions where we are going to be having a blood vessel involvement, that's something that we have made a mention of in our discussion of the kidney chapter as well. Hyaline arteriolosclerosis going to be responsible for having an association with diabetes, hypertension, and aging, and is going to be responsible for causing leather green kidney, whereas hyperplastic arteriolosclerosis would be associated with flea-bitten kidney in the patients. We talk about now example of a condition which is not going to be causing narrowing of the lumen, but which is asked in the exam because it is going to be causing involvement of the tunica media, and patients are going to be having the presence of dystrophic calcification. Because calcium is being deposited over here in the tunica media, this can be picked up with the help of von Cosa and alizarin red. The condition I'm talking about over here is Monckeberg sclerosis. The patients are going to be having the presence of thick palpable vessels, but good point is there is no narrowing of the lumen. The other condition that is going to be a very commonest cause of development of aneurysm formation is atherosclerosis. The pathogenesis of atherosclerosis is endothelial cell injury. There is going to be oxidation of LDL. This oxidation of LDL results in the formation of foam cells, and there is going to be an entry of the cholesterol which is going to be seen inside the vessel layer. The patients can have involvement of multiple vessels, out of which the characteristically involved vessels include abdominal aorta, patients are also going to be having the involvement of the coronary vessels, and they can have involvement of the popliteal artery. Amongst the peripheral vessels, it is a popliteal artery that is going to be characteristically involved. And if there is involvement of the coronary vessels, it's the LAD which is affected, left anterior descending artery. That explains why the patients are going to be having a high risk for development of an anterior wall myocardial infarction. A second reason where the patients can be having a trouble in the vessel can be because of aortic dissection, which is seen because of a weakness in the vessel wall, which can be attributed to something like the cystic medial degeneration. As a result of which, patients can be having a condition in which there is going to be an increase in their blood pressure followed by very severe pain, which is going to radiate to the back. Why that happens is blood flows in the lumen, blood also finds a path in the vessel wall. So that is going to be associated with the finding a double barrel aorta. Double barrel aorta, that's what we need to remember in these patients. Double barrel aorta, it is what is going to be seen in these patients having aortic dissection. Whenever we are going to be talking about the detection of elastin fibers over here, for the purpose of demonstration of cystic medial degeneration, elastin fibers are going to be picked up with the help of a special stain that is given the name of Movart stain. Movart stain, right? With respect to syphilitic aortitis, thankfully, which has become very, very rare, we are having better treatment and we are having better awareness amongst people as well. This is going to be associated with Treponema pallidum causing involvement of the vessel, which is given the name of tree bark appearance, primarily because of patchy fibrosis. And if there is going to be syphilitic involvement, it can result in development of aortic regurgitation. If there is aortic regurgitation, the size of the heart is going to increase. That's what is going to be given the name of cor bovinum. Cor bovinum is what is going to be seen. When we are talking about Raynaud's phenomena, this is an example of an idiopathic condition most of the times in which there is a spasm of the vessel suddenly, quite commonly because of either a vibrating activity or because of exposure to cold temperature. Where because of a sudden vasospasm, you are going to be having the tissues which are going to be now becoming white. As the vasospasm is going to reduce, we are going to be having the tissues becoming blue. And once the blood supply is completely restored, the tissues are going to be becoming red. So white followed by blue followed by red is the characteristic change that you're going to be having in a patient who's going to be having Raynaud's. Raynaud's can also be seen in case of complication of conditions like atherosclerosis and maybe at times with sclerosis as well, and therefore it can be an example of secondary Raynaud's as well. Most of the people would benefit if they are going to be exposed to something like a warm temperature, or if you put their fingers in a warm weather, or at times they may require administration of drugs which are peripheral vasodilators. So that's what you need to remember so far as the different kinds of pathologies affecting the vessels are concerned. Let us not forget about one or two words important about the tumors over here. One of the commonest tumors that you're going to be having in the vessels is going to be capillary hemangioma, which is a very common vascular tumor. And the good point about this kind of a tumor is that it regresses as the age of the baby is going to increase. So 70% chance of a regression by 7 years of age. There is going to be a collection of blood and you are having a minimal connective tissue which is going to be present. We then have a tumor that is going to be given the name of an angiosarcoma, very rare tumor, highly malignant in nature, but the risk factors have been asked in the exam time and again. Tap your brain, there comes the answer. Thorotrast, arsenic, polyvinyl chloride. Because it is arising from the endothelial cell, so what can be the possible markers? Of course, von Willebrand factor can be a marker. And another marker that we have is a PCAM molecule. So PCAM molecule, the one that we study in inflammation as well with transmigration, that is a marker so far as angiosarcoma is concerned. If you are having the involvement of the veins, the venous involvement is what is going to be given the name of a cavernous hemangioma. Cavernous hemangioma is an example of a condition in which there is a collection of blood, but you're going to be having big sized blood filled cavities which are related with the connective tissue stroma, right? So this is what is going to be given the name of a cavernous hemangioma, and cavernous hemangioma is associated with the presence of Kasabek-Merritt syndrome, the one that we talked about in association with our discussion of the hepatobiliary tumors, right? Then we are talking about something which is given the name of Kaposi sarcoma. Kaposi sarcoma is what is going to be associated with human herpes virus subtype 8. It's one of the examples of the AIDS-defining malignancies apart from the presence of cervical cancer and the non-Hodgkin's lymphoma as well. Kaposi sarcoma, please remember, is going to be causing an involvement of primarily the skin affecting the lower limbs. So those are the example of basic facts with regards to the vascular tumors. Having a word now about the ischemic heart disease. The ischemic heart disease is going to be responsible for causing either a reversible cell injury, that is angina, or that can be responsible for causing irreversible cardiac tissue injury in the form of myocardial infarction. If we talk about myocardial infarction, the patients are going to be having a characteristic presentation in the form of a severe chest pain. They would be having profuse sweating, diaphoresis. They would be having the presence of nausea. They would be having the presence of collapse of their BP as well. And 1/4 of patients, about 20-25% of patients are going to die in their very first heart attack. If we take the histological examination of the cardiac tissue in a patient who has suffered from myocardial infarction, we are going to be having certain specific findings. One of the earliest findings that are going to be observed in these patients in the cardiac tissue is going to be waviness of the fibers. waviness of the fibers. Because we are talking about an infarct over here, so obviously we expect to have the presence of necrosis. And the moment we are thinking in terms of an infarct, the type of necrosis that is going to be seen in the patients is going to be coagulative necrosis. So let us have a quick recap with regards to the findings over here with regards to in the time-bound periodic manner. So the earliest finding that we have over here is going to be the waviness of the fibers, followed by between the patients are going to be having a coagulative necrosis. This coagulative necrosis is going to be followed by neutrophilic infiltration, right? The neutrophilic infiltration, of course, is going to be minimal initially. It increases on the second day. It also is going to become maximum on day 3. After day 3, neutrophils get replaced by macrophages. So you are going to be having macrophage infiltration beyond 3 days. You're also going to be having the presence of hyperemic borders of the infarct because of deposition of the granulation tissue. By 7 to 10 days, the amount of granulation tissue becomes very high. So this is what is going to be associated with the presence of a yellow tan color which can be seen grossly. And now collagen deposition is going to keep on increasing over here in due course of time. What you need to remember over here is between 3 to 7 days, the tissue is having lot of fragility. It is very fragile. And because of this particular reason, between day 3 to day 7, there is a very high risk of development of a cardiac rupture syndrome. What we asked in the exams are times are example of conditions where the patients have suffered from a heart attack. They have been brought to the hospital in the earliest possible time. In following the protocol, they have been given a thrombolytic therapy. Majority of the patients are going to improve. But what the question talks about is on administration of thrombolytic therapy drugs, the patient actually worsened. His enzymes actually increased from the previous value. So this condition in which thrombolytic therapy is causing worsening of the condition of the patient is being given the name of reperfusion injury. Reperfusion injury. Why should we be aware about reperfusion injury? Because that's an example of an injury that is seen in association with free radicals. Because of more blood suddenly gushing towards the heart, you're going to be having the presence of eosinophilic bands which can be seen in the cardiac tissue, which is going to be given the name of contraction band. So calcium causing contraction in a patient having reperfusion injury, that's called as contraction band. This is exactly how the contraction bands are going to be looking like. So contraction bands are going to be characterized by the presence of the eosinophilic or the reddish lines that are going to be appearing in a patient who has been given the thrombolytic drug. Now, how do we make a diagnosis of this condition? Gross appearance of the heart is going to be characterized by the presence of a pale area, and normal tissue is going to be having a brick red color. The stain that is being used for this very purpose is going to be given the name of triphenyl tetrazolium chloride or TTC. When this reacts with the lactate dehydrogenase enzyme, it is going to be responsible for causing a brick red color to the normal tissue. It causes pale yellow appearance of the gross tissue of the infected area. Second thing that we need to remember over here is with respect to the different types of enzymes. So the earliest enzyme which is going to be increased in these patients can either be a heart fatty acid binding protein, or you are asked a question 2024 about a protein which is given the name of IMA, that is ischemia modified albumin. These proteins are not very specific for making a diagnosis of myocardial infarction, but they have got the presence of a negative predictive value, which means that if they are normal, then it is easier for you to rule out a heart attack. If they are present, they may or may not suggest of a heart attack, but if they are not there, for sure you can rule out. So ruling out is predicting out, and that's what is going to be seen as a practical utility of these ones. So for all practical purposes, we still continue to use in the hospitals an important example of an enzyme estimation, that is a cardiac troponins. Cardiac troponins remains one of the best enzymes for having high sensitivity and high specificity. They are very, very useful practically for making a diagnosis of reperfusion injury as well. And therefore, overall, they are the best enzymes for making a diagnosis of myocardial infarction. Having said that, we need to have an idea that in patients who are going to be having myocardial infarction, we also are also going to be showing a phenomena of flipping of the LDH ratio. So normally, if you look at the LDH enzyme that is present in the blood of a normal individual is LDH2. LDH2 is more than LDH1. But in case of patients having heart attack, LDH1 becomes more than 2. So this is called as flipping of the LDH ratio. So flipping of the LDH ratio is a feature of myocardial infarction. That is what is to be kept in mind. Having said that, we need to be familiar with the example of next important condition, high yield question, which is asked in the exam, that is rheumatic heart disease. So an example of a type 2 hypersensitivity reactions, children are going to be having a history of suffering from a sore throat caused by group A beta hemolytic streptococcus. There is cross-reactivity and spreading of the cryptic epitope. M protein of the bacteria is going to be having a resemblance with the glycoproteins of the tissues like the joints and the cardiac tissue, and therefore the patients are going to be having rheumatic heart disease. The pathognomic finding, I repeat, the pathognomic finding of rheumatic heart disease is Asher's body. It can be seen anywhere, but it is classically seen in the myocardium. This pathognomic structure is what is going to be associated with the presence of fibrinoid necrosis. It is having the presence of big size modified macrophages, which are given the name of caterpillar cells. Fibrinoid necrosis, big size modified macrophages, which are given the name of caterpillar cells, which are going to be seen over here. Of course, there is going to be a presence of lymphocytic infiltration as well. The importance of knowing about this kind of a condition is that endocardial involvement is seen in the form of valvular involvement. The most commonly affected valve in these patients is mitral valve. And in the sequence, mitral valve, then you have aortic valve, then we are going to be having tricuspid valve, and then pulmonary valve. Mitral valve involvement in the patients in the initial condition or in the acute phase of rheumatic fever can result in mitral regurgitation. But over a period of time, what would happen is that there is a deposition of the fibrous tissue and calcium. Once there is a deposition of the fibrous tissue and calcium, this is going to be responsible for causing mitral stenosis. And once the valve is going to become narrow, mitral stenosis, this is going to be associated with terms like fish mouth stenosis or buttle horn stenosis. In fact, certain keywords, if you're going to be having the involvement of the outermost layer of the heart in these patients, that is associated with a fascinating term, the bread and butter pericarditis. Now, whenever you're going to be having a damage to the endocardial surface of the heart, there is going to be a deposition of the platelets. There is going to be a deposition of fibrin. Such depositions are called as vegetations. So important questions are asked in the exam with regards to vegetations, and therefore we just quickly have a revision about the properties of a vegetation that are seen in a patient having rheumatic heart disease. The vegetations, as you can characteristically see, are going to be present, they are small in size. They are very tightly attached, that means they are firm, and they do not contain a bacteria, so they are sterile. These vegetations have an important anatomical location. They are present along the line of closure. Because they are tightly attached, so no chances of embolization. Similar vegetations can be seen in a patient having merantic endocarditis. Merantic endocarditis can be seen in a patient who is going to be suffering from carcinoma pancreas. Can be seen in a patient who is going to be suffering from acute promyelocytic leukemia. Such vegetations are also going to be small and sterile, but they are going to be having a higher risk of development of embolization. These vegetations are also present along the line of closure. So, merantic endocarditis, remember the risk factors, pancreatic cancer and acute promyelocytic leukemia. And remember the fact that they are having quite similar properties just like rheumatic fever vegetations, but they are having a higher degree of embolization. The moment we think in terms of the most dangerous types of vegetations, what should strike our mind is going to be the example of infective endocarditis. Their vegetations are big, they are bulky, and they are having high chance of embolization. Because of which they are going to be responsible for causing development of bacteria containing emboli, that is septic embolization. One of the complications which can be seen in these patients can be the presence of an abscess, which is given the name of ring abscess. And how exactly do we diagnose infective endocarditis? Modified Duke's criteria. Whenever we are talking about endocarditis associated in a patient suffering from SLE, that's given the name of LSE. So easy for us to remember. LSE, just change the sequence of the alphabets in case of SLE, there you remember the answer. It's an example of vegetation which can be seen on either surface of the valve, but it's more commonly seen on the lower surface of the valve being affected. These vegetations are going to be small, they are going to be sterile, and they are also going to be firmly attached, so minimal or almost nil chances of having an embolization. So all four conditions have different properties of the vegetations which are commonly asked in our exams, and therefore we just need to have an idea about them. Having said that, let us have a discussion about the cardiomyopathies. The cardiomyopathies can be of several types. First example of a cardiomyopathy that I would like you to be familiar with is a dilated cardiomyopathy. Dilated cardiomyopathy means there is a dilatation, increase in size of the atria and the ventricular cavity. And this is an example of a condition which is going to be associated with multiple risk factors. One can be the patients could be having the presence of something like, I can say over here, patients can be having severe iron deficiency anemia. This could be seen in a patient after pregnancy. This could be seen in a patient because of a history of alcohol intake. So, binge drinking, postpartum cardiomyopathy or severe iron deficiency anemia or wet beriberi, they are the conditions associated with dilated cardiomyopathy. In this condition, what you find is that there is an increase in the size of the cardiac fibers. So, that is given the name of myocyte hypertrophy. Myocyte hypertrophy. So, the cardiac fibers are going to become characteristically big in size, and that is going to be seen as a feature. The second one about which we need to have an idea is given the name of hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is going to be seen in patients because of a problem at the level of the beta myosin chain. Because of the beta myosin chain defect, patients are going to be having couple of problems. Problem number one, in grossly if you look at the surface of the ventricles are going to be having the presence of a banana-like cavity. Ventricles are going to be having the presence of a banana-like cavity. This is also going to be associated with presence of asymmetrical ventricular septal hypertrophy. Asymmetrical ventricular septal hypertrophy not only causes banana-like ventricular cavity, it also is responsible for causing a dynamic obstruction of the ventricular outflow. So this condition is going to be having a finding wherein the patients are going to be having a term given or associated with them banana-like heart, and the patients are going to be having a characteristic history. It's a dynamic obstruction. So whenever the patient will exercise, outflow of the heart is going to go down. That's the reason why the patient is going to be having a characteristic history of collapsing on doing an exercise. So athletes collapsing in the field suddenly, one of the important reasons can be a condition like HOCM. Microscopically, you have a hep hazard arrangement. Hep hazard arrangement so far as the cardiac fibers is concerned in case of HOCM. That's what is going to be given the name of myocyte disarray. Myocyte disarray. So banana-like heart is what is going to be a gross finding, and myocyte disarray is going to be an example of a microscopic histological finding with association with HOCM. Then we are talking about restrictive cardiomyopathy. Restrictive cardiomyopathy can be associated with the deposition of amyloid. It can be seen with fibrosis, and there is going to be a problem in the relaxation of the ventricles. So this was an example of an image that is asked in the exam wherein amyloid deposition around the or pinkish hyaline material being deposited outside the cardiac fibers is going to be seen in the patients. When we're talking about the special conditions, we are reminded of two important conditions. One which is given the name of ARVC. ARVC means arrhythmogenic right ventricular cardiomyopathy. The problem that we have in this condition is it's an example of a condition in which the cardiac tissue is replaced by fatty tissue. So because of this, you are going to be having the presence of a right ventricular involvement, right ventricular cardiomyopathy, and this condition is going to be associated with higher degree of development of arrhythmia as well. What is the reason for this? There is going to be a problem in a gene that is going to be given the name of desmo gene. Sometimes patients are going to be having a condition that is going to be given the name of Naxos syndrome. Naxos syndrome patients are having a problem in plakoglobin gene. These are the patients who not only have ARVC, Naxos syndrome patients not only have presence of ARVC, they would also be having other findings like presence of woolly fuzzy hair. They would be having the presence of Palmar-Plantar keratosis, and these patients are therefore going to be having multiple issues. So Naxos is multiple issues because of a problem in plakoglobin. Whereas if the question says only RVC, that's a problem of desmo gene only. What we are talking about over here now is Takotsubo cardiomyopathy, which a lot of people are usually familiar with. This is given the name of a broken heart syndrome. What we are having over here is a patient having a history of a very severe emotional stress, maybe loss of a parent, maybe loss of a spouse, or for that matter, young patients having heartbreaks. And this is what is going to be responsible for causing a problem in the heart. So it's also called as stress cardiomyopathy. Typically, what is going to be happening inside the heart is during the problem over here, apical portion of the ventricle is what is going to be affected, and there is going to be a ballooning of the apical portion. So extreme stress causes release of lots of catecholamines, and apical portion of the ventricle is what is going to be affected. It is going to get ballooned. At a microscopic level, it is going to be associated with multifocal contraction band necrosis. Multifocal contraction band necrosis. So the shape of the heart is going to be appearing just like a net in which octopus is being trapped. That is what is being given the name of Takotsubo appearance. And when we are talking about the microscopic finding, that is multifocal contraction band necrosis. This is an example of a histological finding of a patient who is having ARVC, in which you find fatty tissue is going to replace the cardiac fiber tissue. So therefore, we are going to be having the presence of a problem at the level of which kind of a gene? Yes, desmo gene, ARVC. If it is ARVC plus woolly fuzzy hair plus presence of thickening of the skin of palms and soles, then it is called as Naxos syndrome. So just keep that particular thing in mind. Talking now about an example of a condition in which there is going to be presence of inflammation of the myocardium, that's called as myocarditis. Myocarditis is going to be typically seen because of viral infections, quite commonly because of something like maybe the Epstein-Barr virus, or for that matter the Coxsackie virus. It is going to be associated with lymphocytic infiltration. And if there is a lymphocytic infiltration, we use a criteria which is going to be given the name of Dallas criteria for making a diagnosis of this condition. Then talking about cardiac tumors. Cardiac tumors, as usually we find for most of the organs over here, what is applicable over here is the commonest cardiac tumor happens to be a metastatic tumor that is coming from the lungs. Primary cardiac tumors, we need to have an idea about atrial myxoma. The moment we are thinking in terms of an atrial myxoma, it's a tumor that is seen in case of adults. It's a tumor that is going to be benign in nature. Commonest site of this kind of a tumor is arising from the left atrium, and this tumor is going to be a kind of a dynamic mobile tumor. So this tumor is going to be associated with causing some kind of an obstruction of the atrial cavity. It's also going to be associated with an echo finding, it's an auscultatory finding, that is going to be tumor clot. Microscopically, the tumor is going to be having the presence of cells which are spindle cells, also called as lipidic cells. Whenever we are talking about a tumor that is going to be given the name of rhabdomyoma, it's an example of a tumor that is seen in case of children. In contrast to myxoma, which was a tumor of adults, rhabdomyoma is a tumor of children. Rhabdomyoma is a tumor that is seen in case of ventricular cavity. And at a microscopic level, it is going to be having cells which are given the name of having the presence of a spider cell appearance. We have specific associations of rhabdomyoma, particularly the most important one to be kept in mind is with a condition that is given the name of tuberous sclerosis. So patients having tuberous sclerosis, if you recall, they are having a renal tumor as well. They are having high risk for development of skin problems as well, high risk for development of epilepsy as well, having a development of the presence of something like a cardiac tumor as well. So kidney is involved, heart is involved, the skin is involved, the brain is involved. That's what you need to remember so far as tuberous sclerosis and rhabdomyoma association is concerned. So this takes care of a discussion of the pathologies which are going to be affecting the cardiac tissue. And that takes care of a discussion of the cardiovascular system. Now we have a discussion about an organ that we're going to be using very frequently so as to crack the questions in the exam. And I'm talking about the brain. So as and when we are making a mention of the CNS disorders, one of the most important areas which is asked in the exam is pertaining to the CNS tumors. And therefore, first we have a discussion about them. Perhaps then we talk about the neurodegenerative disorders. The first example of a CNS tumor I would like you to keep in mind, friends, is glioblastoma, which is an example of a WHO grade 4 tumor. Its importance lies in the fact that it is going to be very common and it is highly aggressive. So it is going to be the most common primary brain tumor that we are having in case of an adult. And the significance lies in the fact that grossly if you see this particular tumor, it is going to be crossing the midline. Therefore, you are associating it with the term. It's also being referred by the name of a butterfly tumor. The same thing is something that can be picked up on the radiological investigations like the CT and MRI as well in the patients. What we need to remember over here is at a microscopic level, the tumor is going to be characterized by the presence of a infiltrative growth pattern, and there is presence of a serpentine or a zigzag kind of necrosis that you have over here. Around the areas of necrosis, the tumor cells are going to arrange themselves in a fashion, and because of the necrosis, the tumor cells are arranging themselves in a fence-like fashion. So this is given the name of a pseudo-palisading pattern. Right. So the terms butterfly tumor and the presence of a pseudo-palisading pattern or the presence of an endothelial cell proliferation, that is what is going to be associated with glioblastoma. Significance to like about glioblastoma is with respect to its aggressiveness, it's a highly aggressive tumor. So it's called as a grade 4 tumor and therefore it is going to be associated with a poorer prognosis. The second thing that we need to remember is a tumor which is also going to be derived from the astrocytes just like the glioblastoma, but this one is going to be called as pilocytic astrocytoma. Pilocytic astrocytoma is an example of a tumor which is going to be very commonly seen in case of children, and this tumor happens to be a benign tumor. So it is also derived from astrocytes, but difference number one, age group is different. Pilocytic astrocytoma is a pediatric tumor. Difference number two, pilocytic astrocytoma is a benign tumor. Difference number three, pilocytic astrocytoma is a low grade or a grade 1 tumor, so it's going to be having a good prognosis. If we talk about the site where the pilocytic astrocytoma is going to be present, the pediatric pilocytic astrocytoma or the juvenile pilocytic astrocytoma is something which is going to be present in the cerebellum. So it is going to be present in the form of a cerebellar mass. That is what we need to remember. At a microscopic level, the tumor is characterized by the presence of PAS-positive eosinophilic fibers. PAS-positive fibers, eosinophilic fibers, which are going to be given the name of Rosenthal fibers. The moment you think in terms of a flower like rose, obviously you remember it is going to be having a pink red appearance. So eosinophilic color. So PAS-positive eosinophilic Rosenthal fibers are going to be seen as a feature of this kind of a disease. The third important tumor about which we need to have an idea is given the name of a meningioma. Meningioma is also an example of a benign tumor. And this is an example of a tumor more commonly seen in case of females, more likely to be seen in case of an adult. And this tumor is going to be arising from meninges. Now we understand that there are going to be three meninges, the pia mater, the arachnoid mater and the dura mater. So meningioma is going to be having its origin from the middle layer. That's going to be the arachnoid mater cells, right? Now this tumor is going to be having a radiological finding. It is going to be associated with a tumor attached with the meninges. So it is going to be associated with the term, the MRI finding, dural tail sign. Microscopically, the tumor is going to be having the presence of cells. And these cells can be having the presence of the meningothelial cells, having the presence of calcium deposition in this fashion. So as we made a mention of in our discussion earlier as well, this is going to be associated with the finding the presence of semoma bodies. So the brain tumor with the semoma bodies, that is what you need to remember so far as a meningioma is concerned. Interestingly, meningioma is also going to be having on its surface the expression of the progesterone receptor. Next tumor about which we need to have an idea is given the name of an oligodendroglioma. Oligodendroglioma is an example of a malignant tumor. The name gives you a hint regarding its cell of origin. The cell of origin over here is an oligodendrocyte. Quite commonly, patients are going to be having mutations in the enzyme, the isocitrate dehydrogenase enzyme subtype 1 and 2. Importance knowing about this tumor is going to be causing involvement of the frontal lobe, and this tumor is going to be having the presence of a calcification. Now, because you have an involvement of the frontal lobe, so patient is going to be having a disinhibited way of talking. At times, patients are going to be having the behavioral changes. So, normally you think in terms of a tumor, you would think in terms of findings associated with increase in the intracranial pressure. But this tumor patient is also going to be having behavioral changes as well. So, frontal lobe tumor, calcification, behavioral changes in the patient, increased intracranial tension, and the presence of calcified mass on the radiological investigation, all that goes in favor of an oligodendroglioma. Whenever we are talking about this tumor cells over here are characterized by the fact that around the nucleus there is an empty area. So this is going to be associated with the term the perinuclear halo. The perinuclear halo, what is being described over here by the name of fried egg appearance. So oligodendroglioma, the way we remember it, oligodendroglioma, this is going to be having the presence of a fried egg appearance. That's what we need to remember. Talking then about a tumor, it's given the name of a medulloblastoma. Medulloblastoma is an example of M for medulloblastoma, M for a malignant tumor. This tumor is going to be seen in case of children, and this tumor is going to be again arising from cerebellum. So what you need to remember is that the pediatric tumors, that is the tumors which are going to be seen in children, are going to be arising from C for cerebellum. That's how we remember and crack the questions. Medulloblastoma is a tumor which is going to be having an important finding. It is going to be presenting in the form of a midline posterior fossa mass. And this being a malignant tumor is characterized by the fact the tumor cells are going to be moving from top to down. So therefore, there is a CSF spread. That's point number 1. And fact number 2, it is associated with the term drop metastasis. At a microscopic level, this is an example of a tumor which is going to be having a neuroectodermal origin, and therefore tumor cells over here are going to be small size tumor cells. They are going to be having the presence of extensive amount of chromatin in them. So they are going to be having an appearance, they are example of small round blue tumor cell category. These tumor cells, because they are metastatic in nature, malignant in nature, and having highly aggressive nature, they are going to be having high rate of mitotic activity. Tumor cells are going to be arranging themselves in a flower-like fashion, and therefore we are using a term for them. This is associated with the term Homer-Wright rosettes. Homer-Wright rosettes. Then continuation of a tumor that is given the name of a schwannoma. Schwannoma is an example of a tumor which is arising from the cerebellopontine angle. It quite commonly arises from the inferior vestibular nerve, that is the 8th cranial nerve, and you can be having its association with NF2 gene. At a microscopic level, you are having the presence of spindle-shaped tumor cells. There could be an area where the number of tumor cells are going to be more, so that's given the name of an Antony A area. And there could be a less cellular area which is given the name of Antony B area. If you look at the Antony A area, this is going to be having the tumor cells arranging themselves in a palisading fashion, and you would be having the presence of nuclear free zones which are going to be given the name of Verrucke bodies. So when you are reading those terms in the question of the exam, Antony A area, hypercellular area, Antony B area, which is the hypocellular area, and you read about a term which is going to be given the name of Verrucke bodies. Verrucke bodies simply means the nuclear free zones that you are going to be having, in a patient who is going to be suffering from a schwannoma. Please be familiar with the fact that if a patient is going to be having bilateral schwannomas, that is very much suggestive of a NF2 gene mutations that is associated with neurofibromatosis subtype 2. Having said that, we just talk about a tumor that is given the name of a CNS lymphoma. CNS lymphomas can be associated, subtype is usually going to be a diffuse large B-cell lymphoma. This can be seen in a patient who is going to be having an immunosuppressive condition. Say, for example, a person is suffering from AIDS. And what we are having in case of a primary CNS lymphoma is that the patients are going to be having the presence of what is given the name of hooping. Hooping simply means that you are having the presence of elastin fibers. Please be familiar with the fact that a patient who is going to be having the CNS lymphoma, this can also be seen because of secondary conditions as well. But just remember the fact it's a primary variant which is going to be more common, associated with immunosuppression, and is going to be associated with hooping. Having a word about the neurodegenerative disorders, the first one and the important one that is to be remembered over here is Alzheimer's. It is going to be the most common reason for development of senile dementia in case of humans. Patients are going to be having initial involvement of the temporal lobe, and what we have over here is that it is a Meernet nucleus which is going to be affected in the patients. This condition is going to be associated with a degeneration of the neurons, therefore responsible for causing lowering of the concentration of acetylcholine. Grossly, the brain of these patients is going to be showing you the presence of atrophy of the cortical region. So there is a cortical atrophy. And there are certain risk factors that we need to remember apart from age of an individual. The Alzheimer's disease is more likely to be seen in a person who is going to be suffering from trisomy 21. The reason attributed is trisomy 21 contains a gene which is called as APP gene. This APP gene results in the formation of amyloid beta plaque, and the amyloid beta plaque is responsible for causing the degeneration of the neurons. Other genes which may be associated over here are the presenilin gene 1 and 2, and we can be having an association with apolipoproteins. Important fact that you need to remember, apolipoprotein E4 is associated with increased risk of Alzheimer's, whereas apolipoprotein E2 is going to be protective in nature. So 4 is more, 4 more, higher, and 2 is less, and that's what you need to remember is going to be lowering for protective for Alzheimer's. At a microscopic level, the findings that we have in a patient having Alzheimer's include the presence or deposition of the amyloid beta plaque. That's important. Patients are also going to be having the presence or deposition of the tau proteins. The tau protein deposition is in the form of the neurofibrillary tangles. For the identification of the neurofibrillary tangles, you are going to be using a special stain, and that special stain has been just a one-time question. Still, you need to be familiar with it. It's called as the Balchowski silver stain. Of course, a standard thing that we are asked in the exam, patients having Alzheimer's are going to be having the presence of reddish inclusions or eosinophil inclusions, which are given the name of Hirano bodies. So cortical atrophy, senile dementia, marionette nucleus, degeneration of acetylcholine, involvement of the temporal lobe, presence of amyloid beta plaque, neurofibrillary tangle, Balchowski stain, Hirano body, apolipoprotein E4 and E2. Those are the important things that you need to remember about Alzheimer's disease. The second one about which we need to have an idea is a condition that is given the name of frontotemporal dementia. One of the classical examples of this happens to be Pick's disease. Now, the name gives you a hint, frontotemporal. So, patients are going to be having an initial involvement of the frontal lobe. Therefore, the patients are going to be exhibiting personality changes. And important is that dementia is going to be a late feature. So, in case of Alzheimer's, dementia was an early manifestation, whereas in case of Pick's disease, dementia is going to be a late manifestation. Cells are going to be swollen up over here. They are going to be given the name of Pick cells. So, neurons are swollen up. They are given the name of Pick cells. And they are having the presence of intranuclear inclusions. They are having the presence of intranuclear inclusions, which are going to be given the name of Pick bodies. So, Pick cells, Pick bodies, finding of Pick's disease. Important fact that you need to remember about the frontotemporal dementia is, it is going to be one of the important examples of a condition that is called by or having an important finding at times in patients, especially the familiar variant, that is hexanucleotide repeat. You see, most of us are familiar with the concept of trinucleotide repeat disorders, right? Friedreich's ataxia, or we talk about the conditions like Huntington's chorea. But frontotemporal dementia is an example of a condition in which the patients are going to be having the presence of hexanucleotide repeat. So just keep that particular thing in mind for the purpose of a slightly not so easy question, a tricky question for the exam. Then we need to be familiar with the example of a neurodegenerative disorder, which is given the name of Parkinsonism. For some strange reason, people are very comfortable answering questions of Parkinsonism. The part of the brain affected happens to be substantia nigra. There is going to be a decrease in the activity of dopamine. However, at times there is a relative increase in the activity of acetylcholine. So patients are going to be having mask-like faces. They will be having the presence of bradykinesia. They will be having rigidity. They will be having tremors. There is increased risk of development of seborrheic dermatitis. There is a deposition of alpha-synuclein over here, which is going to be associated with the word Lewy bodies in these patients. Grossly, as you can make out over here, that you are having the presence of dopaminergic neurons over here. So they are going to be having the presence of a dark color over here. But in case of a degeneration, the intensity of the color is going to be less. It may even be appearing quite whitish or creamish, and that is because of the development of a neuronal degeneration. Having said that, one of the often asked topics in the exam happens to be Huntington's. Big time repeat point in the exam. It's an example of an autosomal dominant condition. Hunter is going to put the animal in a cage. Cage has got 4 walls. Chromosome 4 is what is affected. It is associated with a toxicity, gain of a functional mutation of Huntington gene. So there we are having the presence of CAG repeats. Remember, cage, CAGE, where the animal is being kept. Cage, CAG repeats are seen. And because of this cage, you would also remember the fact patients are going to be having the presence of caudate atrophy. Caudate nucleus atrophy is going to be seen. Patients are therefore going to be having C4 chorea, which is going to be seen in high chances with them. The other finding is that these patients are going to be having the presence of enlargement of the ventricles, which is being given the name of the boxcar ventricles. Boxcar ventricles. Patients are going to be having a decrease in the concentration of GABA over here, and they are going to be having the presence of an increase in dopamine. So CAG, that's how we remember it, CANG. Chorea is present, acetylcholine and GABA is going to be reduced in the patients, and the patients are going to be having a relative increase in the dopamine. Therefore, what we are aware of over here is it's an example of a condition associated with trinucleotide repeats. So we anticipate that the next generation is going to be having a worse disease. When you already have a premonition kind of a thing, or you have an idea or an anticipation where the disease is going to be worse in the next generation, that's what is going to be associated with anticipation. So that's what we need to remember. Of course, the drug happens to be tetrabenazine, which has been given in the patients. Just a word or two about the different examples of conditions, which is going to be given the name of vascular dementia. So vascular dementia is going to be a second common cause of dementia in case of older adults. This is going to be associated with development of a low-grade chronic ischemia, which is going to be responsible for a reduction in the cognitive ability over a period of time. Right? Whenever we are making a mention of a condition that is given the name of Creutzfeldt-Jakob disease, it's an example of a condition that is characterized by rapidly progressive dementia. That's the sad part of the story. Rapidly progressive dementia, which is also associated with myoclonus. So that kind of a myoclonus is going to be given the name of startle myoclonus, and it is also going to be having a finding like ataxia. The problem that we have in these kind of patients is an example of a prion disease. It's an example of a prion disease. So this is going to be seen in association with misfolded proteins. Misfolded proteins are going to be causing the trouble, and these misfolded proteins are not going to be destroyed by proteases. Normally, we have a defense mechanism. Even if unfortunately there is a misfolding of the protein which takes place, it should be destroyed. But in this condition, the protein that is going to be produced because of prions is going to be resistant to proteases, and therefore it is going to be persisting. The disease, interestingly, is going to be transmitted by a very strange way, sporadically, that is by the contaminated material, and that can be something like corneal transplant or neurosurgical equipment. What we are having in these patients is a very peculiar finding, that is the presence of a spongiform cortex. And this condition is going to be characterized by the presence of sharp waves of the ECG, which is going to be having the presence of increased levels of the protein. Specific protein over here associated in this condition is the 14-3-3 protein. So those are the keywords that we need to remember regarding the Creutzfeldt-Jakob disease. As and when we are making a mention of a condition that is given the name of HIV-associated dementia, it's an example of a condition which is going to be seen only during the late stages or the later part of the disease in case of HIV. There is a presence of a subcortical reduced function over here, and that is going to be responsible for patients having not only a memory loss, they are going to be having a low mood, they are highly irritable, and there is going to be a problem in their walking as well. That's why mentioning cognitive defects, gait disturbance, irritability, and depressed mood. What you're going to be having in these patients is the presence of diffuse gray matter and subcortical atrophy, and there is presence of microglial nodules, which are also going to be showing you the presence of the multinucleated giant cells. So that is what you need to remember so far as the different subtypes of dementia are concerned. That is what we are asked in the exam regarding the discussion of the tumors as well as the neurodegenerative disorders. Having a quick recap about the disorders affecting the endocrine system, one of the most important organs that you are supposed to remember in the exam, friends, happens to be the thyroid. If I'm talking about the most common reason for development of hyperthyroidism, that happens to be Graves' disease. Patients not only are going to be having the presence of an increased functioning of the thyroid, they also have the involvement of the skin as well as eyes. At a microscopic level, you are going to be having the presence of increased number of cells over here. So there is going to be presence of a follicular epithelial hyperplasia. And this is going to be quite commonly associated with the presence of papillary formation. You would also be having an important finding wherein you can make out the presence of those empty looking areas around inside on the inner side of thyroid follicles associated with the term scalloping of the colloid. So scalloping of the colloid, presence of follicular epithelial hyperplasia and papillary formation, that is what is going to be associated with the patients who are going to be having Graves' disease. The second important fact that we need to remember over here is the condition associated with hypothyroidism, that is given the name of Hashimoto's thyroidism. Hashimoto's thyroiditis is going to be seen as a common cause of hypothyroidism, particularly in those areas where there is going to be sufficient amount of iodine that is going to be present. Right? Now, this condition is going to be associated with increase in the size of the thyroid because the thyroid wishes to synthesize more T3 and T4. But because of the autoimmune problem over here, HLA DR3, DR5 is associated. Female patients who are going to be having, the middle-aged female patients having the presence of an enlargement of the thyroid, they would be having the presence of lymphocytic infiltration. The lymphocytic infiltration actually is going to be responsible for the formation of a lymphoid follicle over here. And what is interesting is the patients can be having presence of cells which are going to be having the presence of an eosinophilic cytoplasm as well, eosinophilic granular cytoplasm. That's going to be given the name of Hurley cells. So both hyperthyroidism and hypothyroidism associated enlargement of the thyroid, Graves and Hashimoto's, are going to be associated with painless thyroid enlargement. So read the question carefully with respect to what is the clinical picture that is being presented to you in the patient. We then are asked about conditions in the exam quite frequently, which is given the name of D. Curvain's thyroiditis. So as we say, D. Curvain causes a lot of pain. It's a history of viral infection in the patients that causes an example of a painful thyroid in the patient, exquisitely painful thyroid. And because it is going to be following a viral infection. So as a viral infection is going to subside, the pain is also going to get better. So it's a self-limiting condition. Maybe patients will be requiring some bit of analgesics in the initial phase, but classical history of a female having a sore throat or a viral infection, then she's having the presence of a painful thyroid, and microscopically it is going to be having the presence of giant cells which are going to be seen, and the presence of the colloid filled follicles, right? So that's what we need to remember over here. We are sometimes asked a question in the exam pertaining to a patient having a thyroid which is very firm and woody thyroid. This is associated with the presence of IgG4 related disorders. And this is an example of a thyroid which is going to be given the name of Riedel's thyroiditis. Just remember the fact, Riedel's thyroiditis is something that you would see in a younger patient. The woody thyroid can be seen also in a patient suffering from a thyroid cancer. But that kind of a thyroid cancer would classically be seen in case of an elderly patient. So cancer is usually seen in case of an elderly individual when we are talking about a woody thyroid, and young patient having a woody thyroid is going to be Riedel's thyroiditis. Having said that, we need to be familiar with the high topic that is going to be thyroid cancer. The commonest type of thyroid cancer that we are aware is given the name of papillary thyroid cancer. Quite a number of these patients are going to be having a history of radiation exposure, and there is going to be an increase in the number of cells which is going to be associated with the finding that there is formation of papillary structures. It's not the papillae. We have told that so many times. It's not the papillae which is going to be diagnostic of a papillary thyroid cancer. It is rather the presence of the nuclear changes. And the classical nuclear changes asked in the exam time and again, orphan NEI nuclei. So you're going to be having the presence of empty looking cells through which you are having the presence of an optically clear cytoplasm as well. That is one finding. Another finding is that there is going to be presence of grooving, or what is given the name of a coffee bean nucleus. So pseudo inclusions which are present associated with the infolding of the membrane in the nucleus, that's a finding that you associate with papillary thyroid cancer. So far as the second cancer is concerned, that is follicular cancer associated with higher risk for development of iodine deficiency, and the patients are going to be having the presence of the follicles which are going to be filled with colloid. Of course, they are also going to be having the presence of Hurley cells. Whenever we are going to be talking about the follicular cancer, the follicular thyroid cancer is going to be having a spread that is through the blood vessels, hematogenous spread. That is in contrast to papillary thyroid cancer, which is going to be having the presence of a lymphatic spread. With the increased frequency, we have been asked a question in the exam, both theory as well as an image-based question pertaining to medullary thyroid cancer. Why? Because this type of thyroid cancer is going to be arising from parafollicular cells. It is going to be also having a lot of times patients are having a familial history because of presence of RET gene mutation. And it is an example of a thyroid cancer which is going to be associated with MEN2 syndrome as well. A characteristic feature of this kind of a thyroid cancer is over-secretion of calcitonin, because of which the patients are going to be having the deposition of amyloid, and that is what is given to you an example of an image-based question. And patients at times are going to be having the presence of neurosecretory granules as well. Let's have a look at the important types of findings that may be seen. When we are talking about a patient having papillary thyroid cancer, that is going to be having an association with the red PTC gene as well as at times the BRAF gene, especially the tall cell variant. This was an INA question. Right? When we are talking about the trouble at the level of the RAS gene, that is going to be seen as a function of follicular carcinoma. And the moment we are thinking in terms of a RET gene mutation, that is going to be seen as a feature of the medullary thyroid cancer. So we are going to be having the presence of orphan NEI nuclei, optically clear appearing cells. That's what is going to be seen as a very characteristically seen finding. Of course, you are going to be having papillary formation, which is going to be having the presence of, at times, increased number of cells. The hyperplasia is going to be seen, and you are going to be having the presence of amyloid deposition so far as medullary thyroid cancer is concerned. Just one final variant about which we can need to have an idea. Anaplastic variant, that is going to be highly aggressive, and therefore it is going to be having a poor prognosis. Remember, the anaplastic variant is the one which is seen in case of elderly patients. And this is the one which is going to be having again a thyroid mass which can be extending into the surrounding anatomical areas like the trachea or the esophagus. Then we need to be familiar with a simple fact that whenever we are talking about the follicular tumors, whether we are talking about a follicular adenoma or we are talking about a follicular carcinoma, FNAC cannot be useful for distinguishing between them. FNAC cannot be useful for distinguishing between them. One of the ways by which you can confirm the diagnosis of a follicular carcinoma is that either you show the presence of metastasis. So metastasis is going to take place. The tumor cells are going to spread from the thyroid beyond the capsule. So there is a presence of a capsular invasion or a vascular invasion. That is what is going to confirm the diagnosis. And the moment I am thinking in terms of something like FNAC, I am reminded of the Bethesda scoring that is going to be seen for the thyroid. Adequacy of thyroid sampling is to be ensured. So the adequacy is that we need to have at least 6 groups of cells, and each group of cells should be having 10 follicular cells each. So if that is the number of cells that you're having, that means the tissue that you're getting is sufficient. It is going to be adequate. 6 groups of cells and each group having 10 cells each. Next organ that we need to have an idea, that is something that we have discussed in renal discussion as well, is diabetes, and the involvement of diabetes is in kidney involvement is termed as diabetic nephropathy. So patients are going to be having initial thickening of the glomerular basement membrane. They would be having nodular deposition of the past positive material that's going to be given the name of the Kimmelstein-Wilson lesion. And over a period of time, this is going to be responsible for causing diffuse glomerulosclerosis. If a patient is going to be having diffuse glomerulosclerosis and he is going to be at high risk for development of chronic kidney disease, and the kind of amyloid that may get deposited in these patients happens to be A beta 2. So those nodules which are present in the glomeruli are associated with the term the nodular glomerulosclerosis. Having just a word about then the adrenal disorders, two important tumors which are asked in our exam time and again. One which happens to be given the name of pheochromocytoma, adrenal medullary tumor that you associate with the rule of 10. So 10% it is bilateral, 10% it is going to be malignant in nature, 10% it is going to be going outside the adrenal gland, that is associated with the involvement of the organs of Zucker-Candle, and 10% are going to be seen in children. Microscopically, tumor cells are responsible for the formation of nest-like structures, and that presence of nest-like structures is what is going to be given the name of Zellbilan, right? Because you are having a tumor which is going to be arising from the adrenal medulla, so there is going to be more secretion of catecholamines and catecholamine metabolites. So one of the ways by which the tumor can be diagnosed or at least screened for is that you are going to be having elevated levels of plasma and urine metanephrines, right? So catecholamine metabolism is going to take place. High levels of catecholamine metabolites, that is metanephrines, would be seen in the patient. When we are talking about an adrenal gland tumor, that is going to be seen in case of children, that is given the name of a neuroblastoma. It's an example of a very common extracranial tumor that we have in case of children. Remember, we talked about neuroblastoma in association with neoplasia as well. It is associated with the overactivity of the N-MYC gene. C-MYC was for Burkitt's lymphoma. L-MYC was for lung cancer. N-MYC is for neuroblastoma. Patients are going to be having the presence of the tumor cells arranging themselves in a rosette-like fashion. So that's given the name of a Homer-Wright pseudo-rosette. And yes, it is going to be having a definitive association with a condition like neurofibromatosis. And an INA question which was asked quite way back, it is associated with the presence of Beckwith-Wiedemann syndrome. Remember the same syndrome that we talked about in association with the patients who are going to be suffering from Wilms tumor as well. So that is what you need to remember so far as this is concerned. Of course, has not been asked in the exam for quite some time, but you need to be having an idea about this being a very, very important pediatrics type of question as well. Prognostic factors within association with neuroblastoma. So if the patient is going to be in the early stage, so let's say that is going to be stage 1 or stage 2 or 4S, that's going to be good prognosis. If the age of the patient is going to be less than 18 months, that is again going to be having a good prognosis. If you're going to be having the presence of a Schwannonian stroma histology, or if you're going to be having the presence of hyperploidy, or if you're having TRK1A, that's going to be associated with good prognosis. Late stage of the disease, N-MYC overactivity, highly aggressive tumor, TRKB expression, loss of type of chromosome 1 or chromosome 11 troubles, that's all going to be associated with the poor prognosis of the patient. So that's what you need to remember so far as the concept of the pheochromocytoma and the neuroblastoma is concerned. Of course, we had a discussion about the condition that is going to be given the name of the multiple endocrine neoplasia syndrome as well. So we talked about something which is given the name of MEN1 syndrome. MEN1 syndrome, which was also given the other important name of Wermer syndrome. Remember the fact the patients were having the alternative name. This is called as 3P syndrome, pituitary, parathyroid and pancreas. Whenever we are talking about a patient who is going to be suffering from MEN2 syndrome, we had a variant that is called as MEN2A. Then we have a variant which is given the name of MEN2B, which is now called as MEN3. Both the MEN2 syndromes are associated with two types of cancers, medullary thyroid cancer as well as pheochromocytoma. MEN2A patients were having a presence of a trouble in the parathyroid as well. MEN2B syndrome patients were having the presence of a tall patient, Marfanoid habitus. These were the patients who were also having the presence of mucosal neuromas. These were also the patients who were having the presence of megacolon. Megacolon. That's what we need to remember over here. So that was about MEN3. And MEN4 is something which is going to be resembling which of these? MEN4 is something which is going to be resembling just like MEN1, but there is involvement of a totally different gene over there. So that's what we need to remember so far as the discussion of the multiple endocrine neoplasia syndrome is concerned in the briefest possible extent as possible. Having now a discussion about an example of an organ, the malignancy of which is going to be the number one cause of problems in case of females in respect to our country. We're going to be having a discussion about the disorders affecting the breast tissue. Now, with respect to the breast tissue, of course, with respect to a path question, the most important topic remains the breast cancer. However, we'll have a quick recap of all the important disorders which are likely to be asked in the exam. Whenever we're talking about the breast tissue, of course, we understand it's an example of a modified apocrine gland in which the TDLU is going to be the functional unit. Multiple reasons because of which the patients can be having a different subtypes of discharges. Say, for example, a milky discharge is going to be associated most commonly with galactorrhea. But when we are talking about discharges like a purulent discharge, that's because of an inflammatory condition like mastitis. Greenish discharge, for some strange reason, exams love to ask you, is because of mammary duct ectasia. And the most common reason for development of a discharge that contains blood happens to be a ductal papilloma. Of course, the bloody discharge can also be seen slightly less commonly in case of patients who are going to be having breast cancer. So whenever questions are asked in the exam regarding bloody discharge, the ductal papilloma is a more common reason in comparison to breast cancer. So far as the inflammatory conditions are concerned, practically what we find is very commonly patients suffering from a condition like acute mastitis, which is seen because of the entry of the bacteria Staph aureus as when the baby is feeding, and the baby is going to be having small cuts are present or cracks are present in the nipple. This is going to be responsible for causing the development of a fever with a purulent discharge, and there can be a development of a swelling as well. Please remember, as is asked in the exam time and again, and might have been told in surgery as well, that breastfeeding is not to be stopped. It is not contraindicated if a lady is going to be having mastitis. Of course, from the other side, that's normal side, the breastfeeding can still continue. If you're talking about Zuska's disease, which is given the name of periductal mastitis, this would be an example of a condition that is more commonly seen in case of females who happen to smoke. And this is going to be associated with development of a retraction of the nipple. This is going to be associated at times with development of a redness as well as a troublesome feature, which is going to be development of a fistula. Mammary duct ectasia is a condition which is what we discussed earlier just now, because of which it is having the presence of a greenish discharge. There is going to be no pain in the patient, but the patient can have a presentation in the form of a subareolar mass. This is something which is going to be seen in case of elderly females, usually in the 5th to 6th decade of your life, primarily because there is a presence of a chronic granulomatous infiltration that is going to be seen. Fat necrosis is something that you would associate in patients who are going to be having a history of either a trauma or surgery, and therefore there is going to be a necrosis. Calcium gets deposited. Whenever there is a calcium associated with necrosis or degeneration, you would associate it with a term like dystrophic calcification. So patients are going to be having the presence of calcium deposition, and at times radiologically, especially on mammography, it may mimic a malignancy, right? Whenever we are talking about the presence of the benign epithelial lesions, that can include lesions which are given the name of the fibrocystic lesions, and that can include lesions like the cysts. There can be fibrosis or there can be adenosis. There is going to be a term that we associate with this. This is given the name of lumpy bumpy breast. And most important thing is, what's the risk of development of cancer in case of an individual having fibrocystic disease? That's about 3%. Whenever we are talking about the next set of lesions, that is given the name of proliferative breast changes without atypia, the relative risk of cancer in these patients is twice, almost 1.5 to twice that of the normal. So normally you're going to be having, let us say, a 3% risk. These patients are going to be having a 5 to 6% risk. And the conditions include epithelial hyperplasia, that can include a condition like sclerosing adenosis, that can include a condition like complex sclerosing lesions, and ductal papilloma. Remember, ductal papilloma, the most common reason for the presence of a bloody discharge of the nipple. We then can talk about proliferative breast changes with atypia. Very dangerous because of the fact the patients are going to be having a 4 to 5 times higher risk of cancers. So basal was just about 3%. Without atypia, the risk is 1.5 to 2 times. With atypia, it is 4 to 5 times. And that means you are having a development of ALH or ADH. ALH means atypical lobular hyperplasia. ADH means atypical ductal hyperplasia. Carcinoma in situ is a condition where the patient is having a carcinoma, but the basement membrane is not affected. And therefore, the chances of this being progressing an invasion and subsequently causing an invasive cancer is going to be around, the relative risk is around 8 to 10 times. So question can be asked in the exam most likely in terms of the relative risk questions. The moment we are thinking in terms of stromal tumors, one of the commonest tumors that is observed clinically on which questions are asked in the exam is a fibroadenoma, and that tumor is also going to be given the name of a breast mouse. This tumor tends to be unilateral, but it may be bilateral, especially in case of an individual, a female who has been put on immunosuppression because of cyclosporine. Gross appearance, the tumor is going to be well defined and it is going to be having the presence of a glistening surface. And microscopically, you could be having the presence of a situation where two variants are present. One which is given the name of pericanalicular variant. Pericanalicular, stroma is around the epithelium. And there can be intracanalicular variant where there is going to be too much of a stroma which is going to be causing a compression. Fibroadenoma, nothing to worry for a female except that, yes, definitely in a lot of conditions, if she is uncomfortable with it, that would be requiring a surgery. A leaf-like lesion that is going to be associated with a tumor in the breast is given the name of phylloides tumor. this is going to be associated with a bulky breast. So leaf-like projections and bulky breast. And this can be associated with, especially in case of an elderly lady who's going to be having the presence of a palpable mass. This kind of a situation, if it is going to be high grade, may be associated with the presence of a hematogenous spread, and the term used is metastasis. Of course, when we are talking about this kind of a condition, from the surgical perspective, a very important thing that you need to remember over here is that axillary lymph node dissection is not to be done over here. It is contraindicated. So those are the example of the findings that are going to be having big leaf-like growths over here. That's what is going to be seen as a finding of a patient suffering from Phil-Lords tumor. Then we are going to be talking about the interlobal stromal tumor, which may include certain names which have been given as option in the exam. So myofibroblastoma, that's the only important fact that is to be remembered, that myofibroblastoma has an equal incidence in case of both males and in case of females. If we are talking about a stromal malignancy, then the commonest stromal malignancy happens to be a tumor that is given the name of angiosarcoma. The moment we think in terms of breast cancer, as I was making a mention of and repeating that, commonest cancer that we have in females in our country, of course, most of you at this particular stage are very well versed with the risk factors, be it estrogen exposure, age, radiation exposure, or for that matter, a family history or multiple females in the same family, or higher consumption of lipids as well as alcohol. All these are important. Protective factors is what is not to be forgotten. Pregnancy is protective, friends. Lactation is protective. Both pregnancy as well as lactation are actually responsible for causing better differentiation of the cells. The well differentiated cells, of course, are going to be the more mature cells, lesser chance of having a cancer. So far as the familiar risk factors are concerned, highly important. We have the BRCA1 gene located on chromosome 17q, more strongly associated with female breast cancer. Such females are also at high risk of suffering from ovarian cancers, right? When we are talking about BRCA2 gene, that's present on chromosome 13q and is more strongly related with the male breast cancer, such males are at high risk of suffering from prostate cancer as well. We should not be forgetting the role that is being played by the P53 gene as usual, as is applicable for majority of the human cancers. And we are having a role that is being played by the CHEK2 gene. Now, if we are talking about the sporadic cancer, usually there is going to be a genetic factor, but also combined with that, there is going to be an exposure to estrogen. So overall, if you look at the gene which is going to be mutated in patients having breast cancer, undoubtedly the answer is clear to you, P53. And may I just help you recall that the BRCA1 and the BRCA2 genes, why are they important? Because they are going to be involved in the process of DNA repair. Remember, along with the Fanconi anemia gene complex. When we are talking about the carcinoma in situ, the carcinoma in situ is going to be having its origin from the terminal duct lobular unit. And the moment we are thinking in terms of the ductal carcinoma in situ, as the name gives you a hint, no involvement of the basement membrane, still can have calcium deposition. There are different subtypes that we are taught about over here, something like, let us say, the Comedo DCIS or the non-Comedo variant. But what I would personally prefer you to be familiar with is the Paget's disease of nipple. Paget's disease of nipple is important because this is going to be involving one side of the breast tissue. It's an example of a lesion which is going to be having a very bad kind of an appearance. It is going to be extremely itchy for the lady. And this is going to be associated with a lot of pruritus. So because of pruritus, she'll do it and there is going to be an ulceration. So presence of a unilateral eczematoid lesion, which is going to be associated with the finding intense pruritus is seen and there is an ulceration of the nipple. Undoubtedly, because you are having the presence of a tumor over here, she is going to be having the presence of a palpable mass as well. One of the important findings that is going to be seen with this kind of a tumor is going to be the presence of Paget cells, right? And these cells, as you are aware, are going to be having presence of lots and lots of mucin, and there is presence of a high expression of HER2. So that's appearance. It's an example of a palpable mass. It is going to be having a intense itching. It is going to be associated with pruritus, and there is going to be a presence of something like a development of an ulceration as well. And that histological appearance is going to be showing you the presence of cells which contain abundant mucin and they're having expression of HER2. So that is what is going to be seen in case of Paget's disease. Making a mention of the lobular carcinoma in situ, why that's important is because it is having an association with CDH mutation and therefore lowered expression of E-cadherin. Remember, cells separate out, so they are going to be having a situation where there is higher risk of development of bilateral tissue involvement. And what we are having over here is that cells are separated out, so that is called as disc cohesive cells. And because they contain the presence of mucin, so that is going to be having the presence of a signet ring appearance. Having said that, we just make a mention of infiltrating breast cancer. Infiltrating breast cancer, again, the site of origin happens to be TDLU. And of course, the cancer that is going to be seen in the patients is going to be adenocarcinoma. Nowadays, what we are going to be following in the patients is going to be the concept of the molecular classification. And as all of you are aware, the molecular classification is going to be based upon the gene expression profiling. So you're looking at what kind of receptor is being expressed, whether it is an estrogen receptor, whether it is a progesterone receptor, or whether it is an example of a HER2 new receptor, right? The moment we are thinking in terms of the estrogen and the progesterone receptors, they are the ones which are present intracellularly. So they are going to be having a nuclear staining. Whereas the HER2 is an example of a ERB-B2. If you remember from our classification that we discussed in context of proto-oncogenes, it's an example of a growth factor receptor. So this is going to be having a characteristic finding that the membrane is going to be having a stain. Now, as you can appreciate over here, the color staining that we are having over here is a brown color stain. So this is going to be seen because of presence of a dye that is given the name of DAB, that is diaminobenzidine. Diaminobenzidine. Whenever we are going to be talking about the immunohistochemistry, we are going to be using the scoring system over here. The score, if it is going to be 0 to 1, is being considered as a negative score. The score, if it is going to be 3, is going to be considered as a positive score. But that is where the trouble arises when you have a score which is called as 2. So you neither call it as positive nor you can call it as negative. This is being referred by the name of an equivocal score. Whenever you have an equivocal score with respect to the staining, you have to go in for a further investigation, and that further investigation happens to be quite commonly asked in the exam. That is the fluorescent in situ hybridization. Regarding that, what to be remembered. Now, looking at the histological classification, some of the tumors are going to be having certain specific findings that we just need to be aware of. So, I would personally recommend you to be familiar with the finding that you have in case of invasive lobular cancer. I repeat that, associated with CDH1 gene mutation, you are going to be having tumor cells arranged in a single lane. So, that's what is being given the name of an Indian file pattern or a single file appearance. Clinical presentation of a patient having breast cancer, of course, is important. Patients are going to be having the presence of a lump. There is involvement of the upper outer quadrant. Patients can have retraction of the skin as well. There can be presence of puckering of the skin as well, which is going to be given the name of Patho4, orange, as we call it that in mispronunciation. And this is because of the Patho4 or the Patho4 is going to be appearance, the orange-like appearance of the breast tissue skin because of obstruction of the lymphatics. The moment we are thinking in terms of something like the male breast cancer, and subsequently then I'll have a word with you regarding the molecular classification again. Male breast cancer is going to be having other risk factors. Say for example, the BRCA2 gene. Can be associated with a very important risk factor, that is Klinefelter syndrome, as well as history of exposure to radiation, or for that matter estrogen. You need to be familiar with the fact, again, the patients over here are going to be having the presence of a subareolar mass, and at a microscopic level, the male breast cancer is typically going to be an example of a ductal carcinoma. Now let us have a look at the important prognostic factors over here. So metastasis remains the most important prognostic factor. If metastasis is excluded, status of the lymph nodes becomes very important. That's the most important next prognostic factor. And breast cancer is notorious for causing involvement of the bones as well, usually the lumbar vertebrae, by which it can be responsible for causing a development of lysis as well. Whenever we are going to be talking about the molecular classification, this is what I was referring to. So I want you to remember fact number 1, gene expression profiling. We have got primarily 4 variants and a 5th variant as one, which is given the name of Claudin variant. But the questions asked in the exam has been on luminal A. So luminal A is the one which is going to be having ER-PR positive and HER2-neu is negative. It is going to be having the presence of a low mitotic index. So the reverse is the way the questions have been asked in the exam, that you have a female who is having the presence of a mass in the upper outer quadrant of her breast tissue. This mass was excised, or there was a tissue which was taken over here. It was subsequently subjected to the examination, and gene expression profiling showed it was having the presence of luminal A. So luminal A means ER-PR positive, HER2 negative, low mitotic index. In contrast, if the question says the patient is going to be having luminal B, it's very similar to luminal A because it is ER-PR positive. HER2 can be negative, it may be positive as well. But the important finding is, in case of luminal B, you are going to be having high mitotic activity. Therefore, in comparison to luminal A, this one is going to be having a poorer prognosis. A third variant that we talk about is the HER2 enriched. This is the one that is going to be seen in case of a younger female, especially associated with P53 gene mutation. ER-PR is going to be negative in these patients and HER2 is positively expressed, and therefore the patients are going to be having a poor prognosis. So far as the basal-like variant is concerned, in this variant, the important point is estrogen receptor, progesterone receptor, HER2 receptor, none of them is going to be overexpressed. All of them are going to be negative. Therefore, it is also being given the name of TNBC, triple negative breast cancer, triple negative breast cancer. That's what we need to remember so far as the molecular classification is concerned. That is important for the perspective of giving a treatment to the patient as well. That's what we need to have an idea. Of course, whenever we are talking about something like the estrogen receptor, we were asked a question in the exam. It is something which is going to be used as an example of a predictive marker. Usually, estrogen receptor is considered to be a friend of the breast tissue, so the prognosis happens to be good. But please remember the fact that estrogen receptor is an example of a predictive marker. Why do we say is that if there is an expression of the estrogen receptor on the tumor cells, of course, anti-estrogen therapy is something which can be given pretty much importantly in these patients, right? If a patient is having expression of HER2 receptor, of course, anti-HER2 receptor, Herceptin like trastuzumab, can be given safely in such patients. So the presence or the absence of the receptors can dictate at least one thing to you, that what is going to be the likely response to the chemotherapeutic agents that you may be using for them. Right. This is exactly what can be asked to you as an image-based question regarding the scoring system I was making a mention of by IHC. So if you're going to be having a strong color over here, that is 3+, that is going to be positive score. No color over here, that's a score of 0. One score is again going to be something which is negative. So both these are negative. But when you're going to be having a light brown score over here, that is where you're going to be going in for further investigation like fluorescent in situ hybridization, so as to confirm the presence of the overexpression, right? And as I made a mention, the brown color is because of presence of what is being given the name of diaminobenzidine. That's an example of a chromophore color that is being used for identifying the tissue over here, right? So that is what is going to take care of a discussion of so far as the breast tissue is concerned. Having a discussion about the next important topic in systemic path, that is going to be a topic of the genital tract. Now, genital tract disorders. The very first disorder, of course, if we are starting off with something like the female genital tract discussion, is going to be the disorders affecting the cervix. And with respect to cervix, practical questions which are being asked in the exam, of course, I believe they are likely to be caught with you in gynecology as well, is pertaining to something like pap smear. So we are using IR spatula and cytobrush over here. The fixative question was asked in the exam. This is going to be typically 95% ethanol. There are going to be different types of stains which we are going to be using, and surprisingly, we got a question in the exam which was on the pap smear asking about the Papa-Nicolau stain, which contains the presence of these important components, where we are having the presence of the light green SF, where we are having eosin Y, orange G6, and Harris hematopsilin. Your sweet will, whether you wish to remember this much detail or not, but at least since it is a previous exam question, my humble recommendation is be aware about in case the question is repeated just like that. We could be having the presence of a situation where the tissue is going to be taken from the transformation zone, that's a squamocolumnar zone, and this is what is going to be histologically useful, because this is where you're going to be looking out for the presence of coelocytes. Of course, coelocytes, you're aware, cells which are having a high NC ratio, they're going to be having the presence of a perinuclear halo as well. Just like a lot of other tissues in the body, a marker of rate of proliferation is going to be Ki67. So those are the examples of the cytobrush as well as the IR spatula, which is easy for you to be aware of. The moment we are thinking in terms of something like a cervical intraepithelial neoplasia, we would be thinking in terms of the virus, and the virus to be kept in mind over here is human papilloma virus. Of course, we are aware the low risk subtypes of the virus 6 and 11 are there, and the high risk subtypes are 16 and 18. Apart from, I can always add 31, 33 and so on and so forth. In the pathogenesis, we had a discussion. E6 is the one responsible for causing underactivity of P53. E7 protein from the virus is responsible for causing underactivity of the RBG. And what is being used for the purpose of vaccine? Yes, we need to remember L1 protein is being used for the purpose of vaccine. So vaccines are available. The names are Cervarix and Gardasil, about which you have an idea. So far as the cervical cancer is concerned, this is going to be having a presentation in the form of a postcoital bleed. Earlier, it was the number 1 cancer in females in our country, but now it is number 2. The number 1 happens to be breast cancer. This cancer is going to be notorious for having a spread at the level of the kidneys, because of which there can be renal dysfunction or failure, as a result of which the patients are going to be dying because of uremia. Screening, of course, can be done with the help of the best method being the visual inspection after acetic acid application. And the second thing that we need to remember over here is that when we are talking about something like pap smear. So repeating that point, VIA is more important than pap smear. Please don't make that mistake. For some strange reason, people are pretty emotional about pap smear. VIA is a better method for screening. Diagnostic test is going to be the biopsy. Of course, we are going to be taking the colposcopic biopsy. And then we are going to be having now the concept of the liquid-based cytology, wherein you are going to be having the cells which are being taken by the cytobrush, and then they are going to be examined for the purpose of making a diagnosis. Having said that, having a word about the vaginal disorders, the ones which have been asked in the exam more commonly are embryonal rhabdomyosarcoma. The reason is it's an example of a pediatric tumor, and this kind of a tumor is going to be having a presentation in the form of a grape-like mass. So it is also referred by the name of sarcoma botrytis. This particular tumor is an example of a condition which is also having the presence of tennis racket cells. Remember, tennis racket cells is what we discussed in case of the presence of the Langerhans cell as well. So Berber granules, tennis racket appearance, and tennis racket cells. So that was tennis racket appearance. This one is tennis racket cells associated with embryonal rhabdomyosarcoma. The other one that we need to remember is something which is of interest to us because of the fact that there was an exposure to diethylstilbestrol, and that was responsible for having a definitive association with the clear cell adenocarcinoma in the patients. Having a word about the uterine disorders, one of the commonest questions asked in the exam is pertaining to endometriosis, which is going to be responsible for the presence of chocolate cysts in the ovary. Endometriosis is going to be the presence of the endometrial tissue outside the ovary, so outside the uterus, and the commonest side outside the uterus happens to be the ovary. Right? We are going to be talking about endometrial carcinoma, which can be associated with a gene like the PTEN gene. And this is going to be having a clinical presentation in the form of development of an irregular bleeding. Two variants that we have for endometrial carcinoma, the type 1 variant and the type 2 variant. Of course, you're aware. The type 2 variant is what is going to be seen in still elderly individuals associated with atrophy, and it is going to be having the presence of a patient having a thin build. Patients who are going to be in the age group of around 60, 55 to 65, they would be having the presence of too much of an estrogen exposure. For example, hypertension, obesity, diabetes are the ones which are going to be having the presence of a type 1 cancer. So type 1 cancer is associated with hyperplasia associated endometrial carcinoma, and type 2 is the one which is going to be associated with atrophy associated endometrial carcinoma. The moment we're thinking in terms of a tumor that is going to be given the name of a fibroid, that is called as leiomyoma. Leiomyoma is going to be associated with an example of a tumor, again because of the relative increase in estrogen, and the tumor is going to be having too many smooth muscles over here. So that is going to be responsible for giving the presence of a whorled appearance. So microscopically as well as grossly, you're going to be having the presence of a whorled appearance. That is what is to be remembered. Of course, it can be progressing into a complication where the patients can be having the presence of red degeneration. They could be having the presence of a hyaline degeneration. They can even be having a development of a subsequent, very minimal but definitely a risk of development of a malignancy as well. So far as a clinical question is concerned pertaining to red degeneration, it will make a mention of the fact that red degeneration is going to be associated with a pro-inflammatory kind of a condition. So patients are going to be having the presence of fever. They would be having the presence of an leukocytosis, and they would be having the presence of an increase in ESR. That's what you need to remember over here with respect to leiomyoma. Having said that, we are asked questions in the exam pertaining to ovarian tumors, and that can be an example of a histology or image-based question more commonly asked in the exam. So we have example of surface epithelial tumors, in which we are going to be talking about a tumor which is given the name of serous cystadenoma. Serous cystadenoma is important because this is an example of an ovarian tumor which is going to be having the presence of concentric rings of calcium deposition. Concentric rings of calcium deposition is what we are all aware. That is what is going to be given the name of semoma body. So if I just have to make a mention of this, serous cystadenoma associated with semoma bodies is what you need to remember. Mucinous cystadenoma is an example of a tumor in which the tumors are going to be having the presence of the cystic mass, and it is going to be having the presence of secretion of mucin. This kind of a tumor is maybe responsible for causing a development of a trouble that is given the name of pseudomyxoma peritoni. At times, a historical question that we need to keep an eye on is Brenner's tumor, in which you are going to be having the presence of one-sided tumor. This particular tumor was having an important finding that it is having a presence of a transitional epithelium. And we are having the presence of an association over here which is given the name of the pseudo-Meag syndrome. Whenever we are going to be making a mention of the endometrial type of a cancer, of course, that is going to be a variant of the clear cell carcinoma. And wherever most of the times we talk about the clear cell carcinoma, we are having the presence of the glycogen which is going to get washed off. So this one is going to be having an association with the P10 gene. Remember P10 gene, that is having an association with the endometrial cancer. So far as the germ cell tumors are concerned, the germ cell tumor most commonly asked in the exam happens to be one that is going to be given the name of a teratoma. Teratoma, which is going to be having its origin from the totipotent cells. It's arising from the gonads commonly. One of the extragonadal site happens to be a mediastinum, and it is going to be having the presence of hair, tooth, cartilage, skin. That is why it is going to be associated with the name dermoid cyst. Whenever we are talking about teratoma, it may have a very peculiar kind of a paraneoplastic syndrome that is given the name of limbic encephalitis. We have a special example of a teratoma, which is a functional teratoma, which is being given the name of struma ovarii. The other important example of a germ cell tumor about which we need to have an idea is a dysgerminoma. And as all of you are aware, dysgerminoma is an example of a counterpart of seminoma. So this particular tumor, if I ask you, is it benign or malignant? Of course, it is malignant in nature. It's an example of a tumor which is likely to be present only on one side. It's just like seminoma, it's highly chemosensitive and radiosensitive, and the markers will be just like that of a seminoma. So it is also going to be having the presence of OCT34, NANOG and KIT. Similar to the question which was asked in the exam with respect to the markers that we have for seminoma. Of course, you need to remember the fact that beta HCG is going to be negative. That is not going to be seen. I mean, that is going to be normal, and AFP is going to be normal so far as this kind of a tumor is concerned. At a microscopic level, you will have sheets of cells that's being termed as polyhedral cells. They will be having presence of good amount of cytoplasm, watery cytoplasm, sheets of cells, watery cytoplasm, and prominent nuclei. If you are going to be talking about a tumor that is given the name of yolk sac tumor, yolk sac tumor is the one which is going to be seen in a younger age group. So in case of girls less than 4 years of age, they would be having two types of markers, alpha fetoprotein as well as alpha 1 antitrypsin. This is an example of a condition. Tumor cells are present in two ring-like fashions. So tumor cells arranging themselves in two types of rings. In between, you are having the presence of a cystic area. That is what is going to be given the name of a glomerular body or Schiller-Duval body. So whenever you're talking about yolk sac tumor associated with cellular dual body or glomerular body, markers are alpha-1 antitrypsin as well as alpha-fetoprotein, right? So that is what we need to remember. The moment we are thinking in terms of a tumor like choriocarcinoma, suddenly what comes to your mind is an example of a trophoblastic tumor. So this is going to be having a marker, which is going to be a hormone coming from the trophoblastic cells. That means beta-HCG, very, very important. And it is going to be having an important finding, the presence of, remember those radiological signs that you read in radio as well as in case of gynecology, the cannonball metastasis. The moment we are thinking in terms of Meek syndrome, we are reminded of a tumor that is given the name of fibroma. So what is fibroma? Patient is going to be having accumulation of fluid inside the peritoneal cavity. That means ascites. Second is the patient is having a tumor, and that tumor is what we are talking about now, ovarian fibroma. And the third component is the patients are also going to be having pleural effusion. Please remember the fact that patients at times can be having a tumor that is going to be given the name of Leydig cell tumor. Patients having Leydig cell tumors are going to be having the presence of rectangular eosinophilic inclusions that are given the name of Ranke cells. So we got a question 2023 on the image-based question on the Ranke cells as well. That's what we need to remember over here. Of course, if the question asked in the exam is about granulosa cell tumor, we need to be familiar with the term associated over here, Cole-Hexner body. 2023's question again. So we are familiar with what we are talking about over here, Ranke's crystals, rectangular eosinophilic inclusions. We are talking about over here Cole-Hexner bodies, which are going to be seen in a patient suffering from granulosa cell tumor. Bilateral ovarian enlargement, which is going to be seen, is going to be given the name of Krukenberg's tumor. That's very commonly seen because of stomach cancer. Which type of stomach cancer? Gastric adenocarcinoma. Of course, you remember tumor cells over here are having the presence of mucin vacuoles pushed towards the periphery. So they would be associated with the term, and the term that you need to remember is signet ring appearance. Exactly what you are having over here, the signet ring appearance that we are making mention. Just like the ovarian carcinomas, if you have to have a revision about the testicular tumors, we just need to be familiar with them. Again, almost a similar discussion. The most commonly asked tumor that is observed clinically in case of middle-aged adults happens to be a seminoma, highly radiosensitive tumor. Same markers, c-KIT, PLAP, OCT, NANOG are going to be there. And we need to remember that when we are talking about the beta-HCG and AFP, they are going to be absent. Beta-HCG and AFP are going to be absent. That should have been written in a different line, but then all of you are intelligent enough to decode that as well. What we are having at a microscopic level, sheets of cells, polyhedral cells, sheets of them are arranged. Watery cytoplasm is there. Prominent nucleoli is going to be seen. They are going to be having a clear appearance again because of the same reason that they are going to be having the presence of glycogen. We do have an example of a tumor that is given the name of a spermatocytic tumor. It is going to be different from seminoma. Even though the earlier name was spermatocytic seminoma, now it is called a spermatocytic tumor. This one is going to be seen in case of elderly individuals, and it is going to be having an excellent prognosis. So age is more, but the prognosis happens to be really good. So far as embryonal cancer is concerned, the embryonal cancer is going to be associated with the fact it's an example of an aggressive tumor, and this kind of a cancer is going to be associated with beta-HCG, AFP, and you are going to be having important finding over here. Just like the seminoma, it is also going to be having the presence of sheaths and glands. The moment we are talking about choriocarcinoma, even though choriocarcinoma is asked as a question to be in the exam, more commonly with respect to the genital tract tumor or the ovarian tumor, but choriocarcinoma can be asked as an image-based question in context of testicular tumor because the tumor is going to be having the presence of a testicular mass and it will be having the presence of hemorrhage and necrosis. Just like over there, we are going to be having the marker which is going to be beta-HCG and it is going to be having the presence of cannonball metastasis. Teratoma in case of the testicular tissue becomes important. Why it is going to become important over here is because again, it is going to be having a high chance of being malignant. So teratoma that we have in case of a female is a dermoid cyst that is likely to be benign. But teratoma in case of a testicular tissue is going to be a cause of concern because that is highly likely to be malignant. And this kind of a teratoma, as you must remember, can be associated with the important feature that is going to be having the presence of a kaleidoscopic pattern. Just like the yolk sac tumor in context of ovary, the yolk sac tumor over here is again going to be having the same two markers, alpha-1 antitrypsin and alpha-fetoprotein. And it is going to be associated with a structure that is given the name of the Schiller double body. So that is what we just need to have an idea with respect to. This is how we are going to be talking about the cannonball metastasis. This is what we are going to be talking about the Schiller double body. So reiterating the fact, one ring of tumor cells, another ring of tumor cells, in between you are going to be having the presence of empty areas. And this is an example of the inclusions that you are going to be having, what is going to be given the name of, just like the other ones that we made a mention, Ranke's crystals. So Ranke's crystals are also going to be seen in case of the Leydig cell tumor that we are having in context of the testicular tissue. And we can be having functional tumors which are going to be given the name of Sertoli cell tumor, which we are responsible for the secretion of estrogen. Having said that, just a word or two about prostate. One condition regarding the prostate obviously happens to be the benign prostatic hyperplasia. That's seen because of the increased levels of dihydrotestosterone. So the transitional zone is what is affected, and patients are going to be having the static symptoms and dynamic symptoms as they read in surgery. There is going to be increase in urgency. There is nocturia. The enlargement of the smooth muscles over here is responsible for a nodular appearance to the prostate gland. And this is exactly what is going to be seen microscopically as well, that there is an increase in the number of cells. So hyperplasia is what is going to be seen. The moment we're thinking in terms of a cancer, one of the important cancers that is observed in case of elderly males happens to be carcinoma prostate. This kind of a cancer is going to be typically an example of an adenocarcinoma. It's quite commonly going to be an example of an adenocarcinoma. In contrast to the BHP, the prostate cancer is going to be arising from the peripheral zone. It's arising from the peripheral zone, and it is going to be causing an involvement of the posterior lobe. As we discussed earlier, BRCA1 is associated with female breast cancer as well as ovarian cancer. BRCA2 is what you are going to be associating with male breast cancer as well as prostate cancer. So one of the genes involved in prostate cancer is the BRCA2. An important finding of prostate cancer would be a clinical question saying about an elderly male. He is going to be having the presence of a lower backache. Why there is a lower backache? Because there is a spread of the tumor cells to the vertebral column, and this is what is going to be facilitated by the presence of Batson's venous plexus. So there is an applied anatomy link, Batson's venous plexus. Also remember the fact that when we are talking about the tumor secondaries over here, the secondaries over here typically are example of osteoblastic secondaries. We do our ask question exam with regards to the way by which we are going to be making a diagnosis of this kind of a cancer. So one way can be the markers. Standard marker is PSA, prostate specific antigen. Another novel marker that I would like you to keep in mind is NKX3.1. Of course, we are making a mention of markers like AMACR if you have seen the list that we discussed in neoplasia as well. Whenever you're going to be doing the physical examination or the rectal examination, you will be having the presence of a nodularity, and the questions are quite commonly going to make a mention of the fact that there was an obliteration of the median sulcus. So on the rectal examination, there is a nodularity, but obliteration of the median sulcus is going to be something that you associate with the prostate cancer. Confirmation is obviously going to be requiring a histological examination. You have to do a transrectal biopsy. And what you're going to be having over here is the name of a staging, which has been asked in the exam earlier. That's given the name of the Gleason's grading. So this is an example of osteoblastic secondaries responsible for the lower backache presentation. Of course, the patients can be having the presence of a perineural invasion over here as well. So this was the brief discussion with regards to the disorders affecting the genital tract.